second day sessions. We have keynote address. After keynote address, we'll be having a technical session in this auditorium till 12 o'clock. Then after that, we'll be having having parallel sessions in different venue, like in conference hall 1 and conference hall 2. We'll be having parallel sessions from 12 o'clock onwards. Then afternoon also breakout sessions will be there. So that is the brief program of today's. So we'll start with the first session of second day of national conference. We'll be having a keynote address on mental health in Indian scenario and overview.
For this keynote address, I welcome Dr. Smita Deshpande ma'am on the stage, please.
Yeah. I don't need this. Maybe you are not visible in the camera. That's why I want to cover my. Good morning all. While we are waiting for the mic, I'll just quickly begin. So today I've been asked to talk about mental health, the Indian scenario. But first of all, I'd like to begin by thanking the organizers. The organizers of this conference and Director NIPED, Dr. Ramkumar, Dr. Amrita Sahai, whom I've known as a very hardworking person for a very long time, and you, dear audience, because without you, we can't really have any presentations or any conference at all. Thank you. I was asked to speak about the Indian scenario for mental health, but I've divided my talk into 4 parts. The first part is, why is mental health important? What does it cost us as far as mental health is concerned? Excuse me for a minute. Can you hear me? No. Can you hear me? Can you hear me now? Yeah. So the first thing I'll talk about is what does it cost? How much do mental disorders cost us? The second part will be on some important Indian surveys which have been done on mental health issues. The third part will be how different are we from the global situation. And the fourth one is that what can you as a health worker, as a mental health care worker, what can you do to change the situation. So India as a developing country, has a triple burden of disease. Why? Because we have one of the largest burdens of non-communicable diseases. We are the diabetes capital of the world. We have some of the highest numbers of injuries in the world. In fact, because of road traffic accidents and mortality, India leads the world in that. It's not a very nice statistic. And we also have a lot of infectious disease burden. So we have infectious diseases, non-infectious diseases and trauma. That's a triple burden, which means that the subsequent consequences of all these issues, there's a very large need for healthcare, right? But when the government spends on healthcare, what are the major heads under which it spends the money? Mostly it's for infrastructure building, making buildings, making various institutions, and making sure that they are maintained properly. And the second thing is increasing the human resource, building colleges, teaching people, or just paying the healthcare workforce, right? So that doesn't really take care of the public health issue of prevention and promotion of health. What happens because of that? Even the amount of public health care we have is very limited, given the large increase in our population. So what happens is that private healthcare is expanding to take over the public healthcare space, and therefore personal spending on health is increasing. As far as health is concerned, government spends only 1.15% of GDP on healthcare, which is a very, very small amount, you will agree. And even less than that, yeah, so even less than that, only 0.5% is spent, less than 0.5% of GDP is spent on non-communicable diseases, which are not killers, but they cause a lot of morbidity and a lot of disability, lot of limitations. In addition to everything, we have a serious mental health crisis. Why? Because according to the WHO, mental illnesses, whether they are common mental illnesses, whether they are serious mental illnesses, whether they are consequent to other causes, they constitute 1/6 of all health related disorders, and that's a huge amount, right? About 1 in 15, 1 in 14, something like that. And in lower and middle income countries, more than 11% of the total disease burden is due to mental health disorders. So again, just this group takes care of almost 11 to 12% of all the healthcare burden of the world. Yet they constitute 11% of the burden, but they get less than 1% of health budgets. So that is actually very, very sad. And in fact, in India, as far as the total years lived with disability is concerned, depressive disorders contribute to about 7%, that's a very large number, and anxiety disorders to 2.5%. So both together come to almost 10% of the years lived with disability. Because both these conditions are very disabling. You may not look at a person and know whether they have anxiety or depression, but nevertheless, they are not able to achieve their potential, they are not able to achieve a good life. That is what the aim of mental health is. Now, what is catastrophic mental health expenditure? If a household has to spend extra money to the extent that it is a burden on the family, that is, and it may take it down from non-poor to poor category, that is catastrophic health expenditure. And Yadav et al. In 2023 published a paper in which they looked at what happens when somebody in the family becomes mentally ill. How much is the expenditure of the family? So, and this was based on a survey, a disability survey, which I'll talk about later. So, you see here that mental illness expenditure was nearly 1/5 of the family's total monthly consumption expenditure. So that if I have a family member who is mentally ill, then 1 out of 5 rupees will go in just treating that mental illness. And actually, if you look at the cost of medicines for mental illness, they are very low. That means because of the inaccessibility or having to spend on private healthcare because public healthcare is not there, people have to spend a lot of money on treating their mentally ill family member. Now, if you look at expenditure thresholds, which is 10% to 20%, then 60 to 33%, 60% to 33% of the families will have catastrophic health expenditure. That means because there is a mental illness, for its treatment, they have to approach a hospital, maybe district hospital far away, or maybe they have to go to a private hospital and get admitted. All this costs a lot of money, and almost 21% of families, that means less than 1 in 5, maybe 1 in 4.5 families or so, become poor from non-poor due to expenditure on the mental illnesses, treating their mentally ill family member. So that's a huge expenditure. So do you agree that mental illnesses do cost a lot? Even if they are common mental illnesses, they may untreated, they become chronic, and they cost a lot, not only to the person himself or herself, but they cost a lot for the family. I hope you agree. Yes, you have first-hand expenditure experience, so obviously you will agree. Now I'll mention a couple of Indian surveys which were done a little bit in the past, but still, surveys are not done very frequently. So these are the numbers which you need to remember. I'll first focus on the 76th National Sample Survey, which actually looked at disability in India. And they looked at a number of parameters from the RPWD Act. I'll just concentrate on a few. Laughably, they found long-term disability to be only 2.2%. That's a very small number, and frankly, it's difficult to believe. But anyway, what this survey also found that rural and urban areas both had disability, long-term disability. Rural areas had slightly more than urban, and disability was slightly less in females than in males. Again, as psychiatrists, we know that depression is much commoner amongst women, both because of psychosocial and socioeconomic factors, and because of whatever other biological factors. So it's difficult to believe that long-term disability was less amongst women than amongst men. It could be because women's disability remains hidden, perhaps because of stigma or whatever other reason. Nevertheless, from whatever figures we have, if we look at just 2% of the Indian population, which is 1.4 billion plus, it's going to be a very huge number, and they are scattered all over the country. Sadly, only less than 30% of these long-term disabled people who were obviously disabled, they had disability certificates, and I think that is a failure of the system, because of disability certificates, people can access so many, at least some healthcare advantages. Again, even amongst disability certificate, there was a disadvantage for females, in the sense that only 1/4 of females had a disability certification, and 1/3 of males had them, right? And very sadly, only 5% could access proper treatment because of money issues, because they didn't have enough money, or because they couldn't access the healthcare. That is why the access was less in rural than in urban areas. So that this is a very sad reflection on the state of affairs. As far as mental health is concerned, we are still depending on the National Mental Health Survey, which was carried out in 2016 in 12 centers all over India. And we are hoping in another 4 or 5 years the next stage will be carried out. But what we found in the NMHS was that 11%, 10.6% of the population had some kind of mental disorder. And the commonest, of course, were substance use disorder. Tobacco was the commonest, 13% of men, less in women. Alcohol use disorder was nearly 5%, and other substance use was also around 5%. So between the three of them, they constituted almost 20-22% of mental disorders, and these are preventable. Drug use is definitely preventable. The next most common category was neurotic and stress related disorders. Now again, I was talking about anxiety and depression. They are also very prevalent in the country. There were urban-rural differentials. The urban metro population had the highest prevalence of mental disorders. Rural somewhat less, but I don't know whether it was because of lack of acceptance or inability to report properly or stigma or whatever it is. Anyway, the numbers tell us that urban and urban metro areas have a greater prevalence of mental illness than rural areas. And very sadly, the most productive age groups are affected. If we look at productive age groups as between 30 to 59 or so, almost half the population half the numbers in this group of population had some mental disorder or other. And common mental disorders are more common, that's why they are called common mental disorders, but they cause morbidity. They may not cause mortality, but they cause morbidity, they cause lack of productivity, they affect well-being, they affect the quality of life, not only of the patient himself or herself, but the entire family. On the other hand, severe mental disorders are less than 1% of the prevalence, but they are lifelong, they are disabling, and they are more burdensome. You treat ID, you treat autism, we treat schizophrenia, bipolar disorder. These are long-term severe mental illness, severe depression. So they tend to recur and they cause a lot of disability. So they cause disproportionate disability. As I told you before, substance use was much more common amongst men than women, and mental morbidity in adolescence was also high. This survey did not look at childhood morbidity, but they looked at adolescents, and even there, 7% of the adolescents had some disability or other, and almost equal amongst boys and girls. This is the worst slide, which makes me feel really sad, that this slide shows that the number of people who have mental morbidity, some kind of mental illness, but cannot access any mental treatment. That is called the treatment gap. And you will see that the least treatment gap is 70% for bipolar disorder, which means if you have bipolar disorder, you have only a 30% chance of getting to a mental health professional, and bipolar BPD, as we know, is an entirely eminently treatable disorder. So for schizophrenia, for psychotic disorders, the gap is 75%. That means if 100 people are ill with psychotic disorders, only 25 people will get treatment for it. So can you imagine the type of burden that the other 75 have to go through? And worst possible is alcohol use disorders. Alcohol use is accepted in society, but stigmatized when it is misused or becomes a substance of abuse. 86% was the treatment gap for alcohol users. Again, it's a very preventable factor. And disability, of course, NMHS looked at disability in different ways: family life, work life, and social life. Whether the person could be a productive member of the family, whether they could integrate into society, and whether they were productive at work. And of course, the highest disability was because of severe depression, next bipolar disorder, and then psychotic disorder. These are all very serious mental disorders. Most importantly, NMHS clearly said that epilepsy as well as intellectual disability are public health issues, and they need to be tackled along with mental illnesses. But the RPWD separates intellectual disability and mental illnesses. Whereas we know as medical professionals that people with ID are more stressed and they tend to have more comorbidity. They tend to have comorbidity with both mental as well as physical illnesses, and you know that better than me. Secondly, the other flag was suicidality. The suicide rate in India is extremely high, and I'll show you that in the next slide. And 3 out of 4 persons with serious mental disorders experience significant disability in work, in family, as well as social life. The economic burden of mental disorders is huge, and the low levels of education and income, as well as lack of treatment for mental disorders, are all linked. India has amongst the highest number of suicide deaths in the world, and again these deaths are concentrated towards the edges of the age pyramid, younger age group and the older age group. This is in fact National Crime Record Bureau statistics. This infographic is from WHO. WHO says that almost 60% of suicides happen below the age of 50. So that's the younger population. Although there is a 36% drop in suicide rate since 2000, but still the suicide rate in India is very high. It's one of the highest in the world, and that is again a cause for concern, because suicide to a large extent is preventable, and at least the repeat suicide attempts are definitely preventable. In 2002, the Directorate General of Health Services carried out a survey, and their findings at that point of time, we had just 3,500 psychiatrists for a 1 billion population. So there was a 77% deficit in India for psychiatrists, 97% deficit for clinical psychologists, and 90% for psychiatric social workers. Although it's almost 20 years back, I don't think the numbers have changed very much. At that point, they had done a survey of mental hospitals because there was a horrifying incident in Yerwadi where mentally ill people were, locked up in a religious place and tied to their beds, and they burnt because there was a fire in the institution, and that is why this survey was carried out. After that, mental health hospitals were upgraded to centers of excellence. They became teaching institutions. The mentally ill patients were sent back to their homes or in their community. But as of today, although in 2002 we had 3,000 to 3,500 psychiatrists, today we just have about 9,000, excluding the annual output of MD psychiatry graduates, many of whom actually go abroad, or most of them are concentrated in the urban population. So we have less than one psychiatrist per lakh of population. And if you look at the 10% prevalence of mental disorders that we saw in the National Mental Health Survey, you can see how much is the deficit. Number of other mental health professionals is also extremely low, and even worse than that, we don't talk to each other. We need to talk to each other to share our experiences and to share our success stories as well. Not only that, we've had the National Mental Health Program for a long time, but there are hardly any monitoring of this program going on. So, in short, the situation in India is not a very happy one. Let's look at the global situation. Is there any difference between the Indian situation and the global situation? Luckily, just last year in June, WHO published the latest World Mental Health Report, and there it clearly says from the beginning that mental health is critically important for everyone, everywhere, at all stages of life. Mental health is an integral part of our general health as well as well-being, and it is a basic human right. Everybody has a right to be mentally productive and to be mentally happy. Mental health, in fact, is a state of mental well-being which enables people to cope with the stresses of life, and we all have to face stresses to realize our ability to the best of the situation, learn well and work well. That means use our learning to bring well-being to ourselves and our families and contribute to their community. So all these features are included in mental health, and if you do not have mental health, you will not realize your potential. Because mental health helps us to connect. It helps us to connect with others and have positive relationships. We learn how to contribute to our communities. We get a sense of belonging and we can empathize with others. That is how mental health helps us to connect. It also helps us to function. We learn how to apply our cognitive skills to gain an education and earn a living, to make healthy choices and learn new skills. And that can only happen when we are mentally healthy. We do not make wrong choices at that time. It helps us to cope. It helps us to deal with stress, to adapt to change, adopt new ideas and bring them into our lives, make complex choices, and understand and manage emotions. And because it helps us to connect, function, and cope, it helps us to thrive. We feel better and better. We realize our own potential. we find a purpose to live, and we start thinking not only of our own well-being but also that of our family and of our community. So these are the positives for mental health. And so one of our aims as healthcare workers should be not only to detect and treat mental disorders but also to encourage mental well-being in those who do not have any disorder. Nevertheless, mental disorders are responsible for almost 16% of years lived with disability all over the world, according to WHO 2022. The global burden of mental disorders in terms of disability adjusted life years is 125 million, which is 5% of all the DALYs. And mental disorders over the world cause more disability amongst women than amongst men. The largest burden, almost 40%, is because of depression and 22% is because of anxiety. These are common mental disorders which need to be detected and treated. 11.2%, 11.7% is because of schizophrenia, which is a serious mental disorder. As compared to that, only 3.3% is due to autism and 7% is disorder due to intellectual disability. Among the top 10 causes of global years lived with disability, within the first 6 you will find depression as well as anxiety. In spite of this huge burden, people don't die of mental illness but they live with morbidity. But mental illnesses are very poorly resourced. They are widespread. 1 in 8 live with a mental health condition all over the world. They are undertreated. All over the world, the treatment gap is 71%. But as I told you, our Indian gap is up to 86%, beginning from 70% to 86%. That's a much bigger gap than in the world, and they are under-resourced. Mental illnesses all over the world get only 2% of the health budgets. In our country, we get even less than that, less than 5%. So what are the risk factors for mental illness? The biggest risk factor actually is poverty, because poverty not only causes burden, disability, but it prevents access to healthcare and it prevents access to the type of technologies that a person can use to improve their mental health. Poor parenting, poor educational attainment and school failure, domestic and interpersonal violence. In fact, one of the very common causes of common mental disorders amongst women is domestic violence. Reduced livelihoods and actual genuine serious mental health conditions, alcohol and drug abuse, and risk-taking behaviors including self-harm. You will see that many of these factors are entirely preventable, and that should be one of our jobs. We don't talk only about treatment, but we talk about prevention and promotion. So according to the WHO, the priorities for action are suicide prevention, because it happens, as I said, amongst the most productive parts of the world, of the population, child and adolescent mental health, and workplace mental health. How many times have you had problems at your workplace because of which you felt mentally upset? So as far as suicide prevention is concerned, limit access to means. Every day we read about gun-related violence and gun-related killings and gun-related suicides also all over the world, especially in the United States. In our own country, there are a lot of farmer deaths because of easy access to pesticides. So these are the kind of means, cooking gas, access to the kind of gas that can kill you. So limit access to means, interact with the media for responsible reporting. You have seen that how much publicity suicides get. It is almost sickening. People should not, in media should not glamorize suicides, and you as mental health professionals should teach your media friends to treat suicide not as a glorified thing, but to underplay it, to reduce it, and to help to prevent it. Foster social and emotional learning for the adolescents and early intervention. So if life skills training can be imparted to adolescents, we heard that paper yesterday about the stress that adolescents face, it helps them to cope with their problems, because we found in one of our studies that psychosocial issues not getting a job or failing at the interview, not doing well in the exams, girlfriend left me, boyfriend left me. Those are the type of psychosocial issues which often precipitate impulsive suicidal attempts. And if they are successful, it's very bad. If they are not successful, it's even worse. So these are preventable means reasons for suicide, and there are also very clearly non-psychiatric interventions that you can do to prevent suicide. As far as child and adolescent mental health is concerned, I know that you are all activists and you are agitating for policies, legislations, improving caregiver support, school mental health programs, and community and safe community and online environments. That is something that we all need to look for right now. And finally, mental health at work. Again, similar types of interventions have to be done, but two simple things if we can do at work: prevent tobacco use and prevent alcohol use, and try to detect depression, support people who are mentally disturbed. Even that much of intervention at workplaces can make a huge difference, and you can begin with your own workplace. So you as a worker, healthcare worker, what can you do to remedy this situation? Well, as healthcare workers, we have four roles. One is to provide care, that we all do. It is our duty. That is what we were taught to do in our colleges. But it is also our duty to promote and prevent illnesses, especially mental illnesses. We need to work in partnership with each other, and we need to support all the related interventions, as I spoke about, gun control or inclusiveness or integration into society. These may not be clearly treatment related issues, but this is something that we need to do. So there are three transformative paths towards better mental health. The first is to understand, to commit, to value each other for whatever we have. The other is reshape our environment. I told you that urban environments are very people unfriendly. Mental illnesses are much more common there and they create more issues. And the third is to strengthen mental health care. So if you find somebody who has a mental health issue, destigmatize and normalize that issue and make sure that the person gets the help that they need. And then we also need to tackle NCDs, because NCDs, non-communicable diseases, remain lifelong, and most of them have mental comorbidity. Cardiovascular diseases and diabetes mellitus have a big comorbidity with depression, and you've seen the burden of depression in my talk today. So even the other NCDs, cancers, cause a lot of anxiety and depression, not only in the sufferer but also in the family. So what does WHO say? How do we tackle NCDs? For that, two simple things which I always talk about: reduce tobacco use and reduce alcohol use. And not reduce, but I would say stop tobacco use. Tobacco is an extremely harmful substance. It causes a lot of morbidity in so many ways. Just stop. And for anybody whom you know is taking tobacco, be sure to give them advice to quit. Not only that, try to be an activist, because tobacco companies will try to advertise and try to induce people to take tobacco one way or other. Tobacco is one of the most addictive substance in the world. Not alcohol, not opioid. Tobacco is the most addictive. Alcohol, harmful use. It would be too much to expect that the society would completely stop alcohol, but at least it should be minimal, it should be occasional, and it should not be harmful to the extent that whole families are destroyed because of alcohol. We did a study in Karnataka on farmer suicides, and one of the major risk factors in farmer suicide was prior alcohol use. That is so sad because it's very preventable. Avoid unhealthy diets, eat natural and whole foods, and then avoid physical inactivity. All of us need to tell our patients not only that you take medicines, but also that maybe you walk half an hour a day, or you do some other work or some other activity, engage in a sport, so that reduces the risk of NCDs to a huge extent. And of course, early detection of diabetes, cardiovascular diseases, chronic respiratory disease, and cancer. I don't need to tell you about that, because that is something that people are probably well aware about. we also need to add mental illnesses to this mix. And as far as partnership in the health system is concerned, first of all, we need to interact with our leadership and with our governance at every level of care, right from the panchayat level to the topmost layer. And it's very easy these days because of the internet. We have to work together for service delivery, make sure that there are enough human resources of every kind for our patients, make sure that assistive technologies and medicines are freely available, agitate for finances, that's more easily said than done, but information. If any of you are approached by the media, if any of you get a chance to write up something, talk something, create awareness, have an awareness building program for mental health, go ahead and do it. So let us pledge to address all these pillars of healthcare to the best of our ability. Always look for novel solutions. I'm very fond of research because research gives us something new to offer to our patients. Also look at social solutions. Social connectedness is a huge uh, barrier to mental disorders, if you like, at least the common mental disorders. And be a teacher as well as a student all your life. Don't stop learning, because learning and then translating that learning into our regular life is a big sign of mental health. So work towards mental health for all. And thank you very much.
Thank you so much, ma'am, for such an insightful presentation, starting from the current status, what exactly mental health is and what is the status in India, and then giving us the directions for how we as professionals should take the action into it. Thank you so much for this wonderful presentation. So now I would request for the participants, if you have any questions, let us have this forum open for discussions and questions, please.
Thank you so much, ma'am, for your wonderful presentation. I have a question. Not question, but actually concern. As a mental health professional, I have seen and I experienced, and you must be aware that Harvard University has conducted a survey. Because in India we are facing very limited resources in perspective of mental health professionals. So I will quote one survey which was conducted by Harvard University, and they were ranking the course. So the first one across the world, first course is economics, and the second is psychology. So what do you think about it? And the second, my concern, sometimes if you are a good student, maybe you are a technical background or something, if you will opt for psychology after graduation, then first of all you will face rejection from your home. So what are the reason behind it? Because I have faced these challenges, because one of the candidate or referral came to me, and both parent IIT background, they were professor in IIT Delhi. They bring their daughter, ma'am, she become mad, she wanted to opt psychology. So what are the scope? So first of all, I would say that I answer to them, you are in the wrong place, because I am psychologist. But this is the scenario. And if we are opting psychology or mental health course, so it is not for the, less recognized as a professional, like engineer or the other this thing. People expect that we are doing charity. So what is your concern in two things? In the
No,
worldwide,
yeah, I'll just ask the audience this question. Did you feel stigmatized, those amongst whom you who are psychologists and social workers, did you feel stigmatized or marked because you took this course? So there's only one hand. No, I think psychology is one of the most lucrative professions you can have in India today. Because, as I said, the burden of mental illness is extremely high. And people hesitate, let's face it, people hesitate to go to psychiatrists. Plus, psychiatrists are so few and they are all concentrated in the metro areas. So psychology, to my mind, is one of the most lucrative and attractive professions that you can take today. I would range everything: psychology, psychiatric, social work. Because given the one day we had a seminar in my department on laws related to mental health, and there are more than a dozen laws. Each of these laws is something that a psychiatric social worker is concerned with, right? So psychiatric social work, occupational therapy, physiotherapy, speech therapy, special education, I think these are the need of the hour. And of course, in such a vast and varied population, there will be people with different opinions. There will be people who will try to stop you if you go to a novel area. But as a professional or as an advisor, as a counselor, it is your duty to tell them what are the scope, what is the environment, what is the what shall I say, horizon that they can look at. That way, स्टिग्मा करना है तो सभी चीजों के लिए स्टिग्मा होता है. आईआईटी वाले नॉन आईआईटी के लिए भी स्टिग्मा कर सकते हैं, या मेडिकल कॉलेज वाले और किसी से स्टिग्मा कर सकते हैं. बट we have to look at realistically. Our economy is growing, our population is growing. There is need for every kind of health service. There's even tomorrow, if they want to become just online counselors, there's a huge market for that. And many MBAs of my that I know of, who did that little bit of organizational psychology and MBA, are turning to becoming life coaches and counselors and things like that, and doing very well. So these mental health professions are quite the need of the hour today. And as our NCD burden increases, they will increase more and more.
Thank you. Thank
I
you so
hope
much.
I've answered your question.
Yes, ma'am.
Madam, you have given a very glimpse of all of the country. Madam, we have a concept called daily disability adjustment and disease burden. Do you think that there is a difference between North India and South India, madam? If so, what could be the reason?
I have no idea, because nobody has done a survey, nobody has done a study. Until we get the numbers, I'm not going to hazard a guess. What NMHS did was look at urban and non-urban areas, and they found that there was little bit of difference. But that difference, I suspect, is not statistically significant. So unless there is proof or evidence, we should not stigmatize, this person has that and XYZ person doesn't have that. We need to, that's a research question. That's something that some of you can look at to try and get an answer.
Okay, thank you.
My question is little on the applied side. Increasingly, we are seeing our lifestyles are becoming very alienated from the functions that the brain is structured for. In a sense that I remember my childhood, I used to play with sand and literally explore the environment. Those opportunities for children at this generation are decreasing now. And we have also seen a strong association between the lifestyle and the kind of problems, particularly cognitive related problems. You think any branch of the psychology could grow into this line, and we can at least make parents aware or the community aware how important it is to respect the way the brain is wired, why these activities are important at a certain age level, so that you can prevent the future problems. Because by the time the manifestations happen, it is too late.
Yeah.
So
very well
I
said,
think
well
this
said.
area is very crucial increasingly. Yesterday when we were talking of autism, I mean 50% of the problems will not manifest if only the brain is respected. But a small example I'll give you. This journals have also reported this, but a lot of YouTube programs are there which emphasize on this. We need to walk at least 2,500 feet every day. That is how the brain is required to do. But we don't reach anywhere near it. And you see how many functions, how many activations which are necessary for the whole body, the holistic health, it's not happening. So I think we need to go back. I'm not saying go back to the Stone Age, but at least to what your brain is still required. Maybe that needs a little more attention.
Yeah, so I'll just go back to the very practical suggestions for um, right. Madam, I do not think we need a psychologist to tell these common sense things. All of us need to do it because that is part of our mental health and healthy lifestyle initiatives. And we not only need, I didn't bring that in here because it becomes too wide. We have to look at something like One Health, in the sense that we need to look at our environment. Need to look at the other, uh, you know, animals, insects, the other life, biological organisms that are around us, and then we also need to look at ourselves. So please remember what Madam said. These were extremely important words, and that is what I meant when I said don't just treat, but give some kind of psychosocial suggestions. And that includes things like a healthy lifestyle, good nutrition, early detection of NCDs, and regular adherence to treatment. And that is something that each one of us as a healthcare worker has to do. When you're looking after a child with autism, you're not looking after only that child or ID. You're also looking after the parents and the other children, because this child's ID is going to affect her parents and her siblings, and through her siblings those that effect will spread over the neighborhood, over the school, over so many other places. So you have to bring that concern into your mind when you give advice to your children or your families. And I don't mean children, by children and families, I don't mean your particular personal family, but any family who consults you. So remember these very, very simple principles when you talk to families, and make sure that you give this advice, good, healthy advice, promotional and preventive advice as well, not just the treatment, not just the medicine, and not just the simple intervention.
I would like that because sometimes you feel that teacher needs some sensitization program because student is going to personally I feel that if a child is going to school and mostly children are staying at a nuclear family, and what we observe in our clinic that after, especially after post pandemic, the child is not exposed properly for the social interaction with the peer group, especially below 6 years or 5 years, and they develop some speech and language delay, and when they entered into the school, so definitely some child is lagging behind. So teachers should be sensitive to give proper awareness and proper training to the parent, or give counseling to the parents, so that which are component are very very important. So of course, as ma'am said that something is very common, ma'am, you are the best teacher, so definitely we are following it.
Thank you. I think I've already overstepped the time. So maybe if any of you have any questions, we can always talk later. Okay, one last question.
Ma'am, this is a very quick question from my end. As like many of us might be trying to educate anyone or try to identify someone needs a mental health, like help from the therapist, but they might be hesitant or may not be able to afford. So how do we push them to identify that they require some help?
If they can't afford, there's some nothing, really you need to then go out and make sure that there are cost effective solutions available. Then you see, if we charge our services very high, that's what I was talking about in public mental health and private mental health. If we charge our services at too high a level, people will not be able to afford. So part of your social responsibility can be developing some simple solutions which the vast majority of people can avail of. Maybe they don't have 5-star services, but at least they can have 2-star services. Maybe they can't access the super specialist in Hyderabad, but at least they can access the primary health doctor or even the ASHA worker in their village so that they start their journey. Because not getting any health care at all is just not acceptable in a democracy. We are all equal, and if 85% of our people don't get the help that they require, that is a shame on us. So we have to reach out and we have to make sure that there are some cost effective solutions which can be availed of. Maybe not the best, but at least good enough solutions so that the child can go ahead, can realize at least some of her potentials.
Thank you, ma'am.
So, Amrita, if I have your permission, I can stop.
Thank you, ma'am. Thank you so much for you are enlightening everyone over here.
One last question I have. When she was talking about teachers, the teachers are the resource for mental health. So, do we have any kind of resources which directly teachers can access? And then, because the teachers also need education, being psychologists and the mental health educators, teachers need some kind of education.
Many more, institution is doing repeatedly training program for the teachers to sensitize them to, create awareness about how to identify the common mental health issues in early, childhood, especially adolescent issues or substance abuse and alcohol abuse. We give such type of training, and NCRT, madam is earlier she used to work in NCRT. So NCRT is doing a lot of training program for the teachers. So of course,
There's plenty of online resources, and if there are websites, government websites, then they give authorized, authentic information. That is something that you can immediately access, and I'm sure if you invite, NIPED or any other government institution, they'll be very happy to come over and do an awareness program.
here also, RCI is conducting lot of programs, not only with the NIPED, but many other organizations with the help of other institute also. So RCI is conducting, NCRT is conducting.
Their website and see NISTHA, NISTHA. So this is the largest training program in India by ministry to educate teachers about mental health and life skills.
And in fact, in NCRT, I know for sure because I was also involved. They are putting out modules for teacher training in various topics, and very practical, easy to remember, easy to use. So if I suppose if you go to NCRT website, you can easily get. Okay, exemplars. They are called exemplars. Okay.
Public, platforms such as YouTube's, Google Baba, whatever you may call it, social media, you will get plenty of information. Even if you don't want to see it, also you have to see it.
Know which ones to choose. That's why I'm saying that go to government websites, and they are authentic and authorized websites.
The YouTube channel also where the programs are published and released for the students and teachers and parents as well every day about every topic and subject, for students also, for teachers also. And yesterday our director sir was also speaking about the YouTube channel of NIPID. So you can visit our website. You can have short-term training program which are for teachers regularly recognized by RCI, and you can visit other websites, official websites of government.
Thank you so much, ma'am, and thank you so much, audience, who are very deliberately participating in this discussion. So we are moving on to the next session. So we have the technical session for the day. So I invite Dr. Usha K, Faculty, Department of Special Education, as the moderator of this session. Usha ma'am, please come over to stage. And I request Dr. Usha K to escort Dr. Smita Avasti, Director, BMI New Delhi, as the chairperson of this session. So our today's first presentation, technical session presentation, will be our own convener of the conference, Dr. Amardasa. Hi, ma'am. So, Amrita ma'am, I don't want to introduce her because everyone knows her, and she's a senior most faculty in NIPIT. And over to you, ma'am.
Thank you, Dr. Ambadi. Thank you, sir. Thank you, Smita ma'am. Thank you, Dr. Usha ma'am. I'm going to present about, building legal capacity among individuals with intellectual disability. Moving forward, what we need to do. So, what is it? UNCRPD, United Nations Convention, Rights of Person with Disability, and in India, RPWD Act 2016 state that an individual with disability have the rights to equal before the law. So everybody has the right. Whatever the right I have, of course, the person with disability, the same right. So all have equal rights to access the right. Court, judge, government does not presume that a person with disability or with the intellectual disability or the other disability is unable to exercise their rights because of their limitations, any other limitations or disability. UNCRPD, it is very important line, all we have to understand. Person with disability enjoy legal capacity on an equal basis with others in all aspects of life. If I have a right to marry, if I have a right to, sorry, this is the adjustment. Person with disability enjoy legal capacity on the equal basis with others in all aspects of life. If I have a right to marry, I have a right to buy a property, the person with disability, they have the same right. And the signatory nations to develop it. Signatory nation, India is one of the signatory nations. So we have to create the appropriate measures to provide access by person with disability to the support they may require in exercising their legal capacity. And as you and me aware that how much they are able to access their right. Legal capacity is what? It means human being can do within the framework of legal system. Legal capacity gives the rights to access the civil and judicial system and the legal independence to speak on one's own self. Guardian is very important, especially in the person with intellectual disability and the other developmental disability. Guardian is the person who is appointed to look after another person. If I have a guardian, it means ki my guardian look after to me or his or her property. He or she assume the care and protection of the person for whom he or she appointed the guardian. Guardian takes all the legal decision, but the guardian should be appointed by the authority. Why we need to create building legal capacity? What is the need? It is written in our constitution. We have an act but definitely we have to understand, being a mental health professional, being a rehabilitation professional, we need to understand why we need to develop it, why we need to create, why UNCRPD is saying that we have to create the opportunity to access their legal rights. All we have dignity, and we should respect for inherent dignity, individual autonomy. If I wear this sari today, this is my choice, this is my individual autonomy. All we stay in family. Family is a very important institution in everyone's life. So within this, important institution, I have an individual autonomy. What I will take decision, it is purely mine, my decision. So that is important. Independency of person. Independency is a very broad meaning, and we have to respect the independency of that. Everyone's non-discrimination. Everywhere we write, we quote that non-discrimination, full and effective participation in inclusive society. Inclusive society, it is not restricted to only in education. I always say and always share this thing. Inclusive is a very broad term. Inclusive, if I want to go to temple, should that environment should be inclusive. It should accept me in any condition. So, and then we can say that we respect the humanity in national and international perspective, not in India, but across the globe. If you will see the literature, there is a lot of paucity of research, first of all, I will say. But 2 3 research article I have gone through. It is mentioned in the conference proceeding also. Please go through. And very important that Salja madam asked, that is the one point we can say, that brain maturation is facilitated through the richness of personal experience at home. Whatever the experience we are giving to the child, it is very very important, and the brain is reacting to this experience. And in school and community as well, as to some extent life experience of the brain and behavior is associated. So definitely, whatever, for example, if a 2 years old child, if we will give the particular toy, the child is playing, child is exploring the things, child is developing some cognitive abilities, some social activities like share or not to share, hide or not to hide, throw or to keep it safely. All this activity is related to brain and the behavior relationship. So that is very good study. So we have to understand why it is important, why we have to give the good experience to the child since beginning. Personal mastery gives satisfaction to people with neurodevelopmental disability after successfully completing a learning task or handling a social situation. Why only learning disability or developmental disability? If I will learn something new today, definitely it will give me lot of motivation. It will give me a lot of self satisfaction to me. So it will applicable to the person with disability also, especially intellectual disability. If you will introduce something new in the class, definitely child will learn. Child will sometimes reject that new opportunity, sometimes they will learn, sometimes show some little effort. It will create lot of motivation towards the success. Exercising choice and making decision about one's own life are important both to personal well-being and individual sense of identity. Personal choice is very important. If I have to choose chapati or rice, I have a choice. I have given the choice. So the child or the person or whosoever is there. So if they have choice, definitely the person will have a better experience, and it will give the it will reflect the good mental health, and it will one of the component of well-being. If we are giving a very good environment, physical infrastructure, educational facility, but if we are not giving the autonomy to pick one or to choose one, to make the choice, then there is no point. So legal capacity and mental capacity, always we say as a professional, we say that person with intellectual disability is not able to take the decision. What are the reason why we are saying it? We have to understand it. Legal capacity is the formal rights to hold and to exercise and duties. Mental capacity is the ability to decision making, skills and competency of the person, which is applicable to me, you, everyone. Legal capacity, everyone has a rights to legal capacity. Everyone has the right. It varies person to person. Sometimes what happen, in a same situation, you will take some other decision, I'll take other decision. It because of our mental capacity. So it vary person to person. That is why we talk in psychology and individual differences very very important. I have taken this decision or I have taken with this problem solving. It vary. It vary because my past experience is different, my exposure is different, my understanding of the problem is different, my conclusion to see the conclusion is different. So that is why individual difference is very very important. So it is one of the important factor. What are the challenges with IDs? If we are talking about mental legal capacity, and we are talking that we need to create legal capacity, so what is it? Of course, if you will categorize four category: mild, moderate, severe, profound. These are the four categories. Within these four categories, we have lot of limitations for mild level of intellectual disability and severe and profound level of intellectual disability. So if we are talking about building legal capacity, it means it is not same for the mild, not same with the moderate, not same with the severe, not same with the profound. Why? Because their mental capacity is different. If adult 20 years old child or man with intellectual disability, mild level of intellectual disability is there, so it means the mental age is 10 to 12 maximum mental age. And if 20 years old, profound level of intellectual disability, not 2 to 3 years of mental age. So vary. Comorbid condition. Smita ma'am has explained that so many comorbid condition, physical as well as mental. So sometimes whatever the comorbid condition, it is also the challenges when we talk about the building legal capacity. Unawareness of their right. I think it should go first. We are unaware. We are very much unaware how to improve, how to give the exposure for the legal building, building capacity for the legal aspect. So that is one of the important challenges, because as a professional, I'll say one example. When I was doing MPhil, and in MPhil course, I think many students are also from MPhil background. One chapter is there in psychiatry, medico-legal aspect. It is in the last, and no single question will come in examination, and this is very boring and never we gone through. But we practice in the our practical life. When the parent asks that what we do, what my son is saying that he want to marry, then I stuck. What I can't explain that you have to go with the genetic test, you have to go, and who has given me the right to tell about this thing? But this legal capacity is very important to understand as a professional. Then we can give the awareness to the parent, because being a professional, first we have to understand. And assessment of cognitive legal ability and decision making. Sometimes we are preloaded with the biasness that the person with intellectual disability will cannot do it. They cannot vote, they cannot go to bank, they cannot buy 50 rupees per liter mother dairy milk. So we are preloaded biasness, because sometimes we as a professional, we as a parent, we are unable to assess this thing. And in assessment, we have certain questions. I would like to share with our experts that NIPID is developing a test, DITI, development of intellectual test of Indian intelligence test, there is a question that we should ask the child, that if nobody is out at home, and if somebody will knock your door, so what you will do? What will be the usual answer? If a child, normal child, or typical children, they will say, I will not open. I'll ask, who are you? But we never asked the option to the person with intellectual disability. They may say that I will not open, I'll call phone first to my mother, or nobody, leave me alone. So many questions. So these kind of aspect, which is where the child can take the decision. This is very important, but we do not have formal assessment, psychological and special education assessment, as per my knowledge. And next is lack of significant family members. Sometimes the child or the person with intellectual disability, they are staying in home where the state government or the affiliated other non-government organization is taking care of the person. Who is taking care? Who is taking decision on behalf of person with intellectual disability? So this is the another challenge. And if you will give me the authority to take the decision, of course I am bounded with so many things, this and do's and don'ts. So this is the another limitation, because there is no clear-cut rule and regulation. Lack of professional guidance and support. We as a professional, we have limited legal understanding. So definitely how we can promote, or how we can give awareness to the parent. So that is one of the important aspects, that we need to orient ourselves about this legal capacity. Increase vulnerability to exploitation and abuse. This is one of the important things. I would like to share a one case example, that I was called by Honorable High Court, Karkaduma Court. The girl child was raped at the age of 14 years, and court seek professional expertise from because the child person with intellectual, their speech was not clarity, and she was not stick to the same statement as the law says, that you have to give the same statement, this and that, if somebody has done something. So it should be inverted comma, and all the time it should be same. So the court instructed us to give the professional suggestion or something, so how we can provide the support to the victim. So we went there, and the other party, I mean what we call the lawyer from the anti party, he was saying, you are saying that person, the girl is intellectual disability, and her mental age is around 9 to 8 years, and again you are saying that child needs support. So how you can say that somebody has done wrong with her? So what is the meaning? Of course there is no standard meaning for that. If somebody has wrong with me, if I am saying that somebody has wrong with me, there's so many hundred sense will come up. So there is a chances of exploitation and with the legal system, because how a child, how a intellectual disability, mild level of intellectual disability, can say that after 6-7 years back somebody raped me. Maybe the child, that girl, was not able to understand the meaning of rape. So how we can expect that she will say that particular statement? So that is the chances of vulnerability and to exploit and abuse. Challenges related to service system. We are providing, many NGOs, many government system, we are providing the health services, rehabilitation services, but very few centers, very few organization is providing the legal support system to the beneficiary or to the parent. Again, I will give you an example. I again called by Honorable High Court, Delhi. So I was surprised that 7 years old child with both parents, sorry, I will finish within time. So the child is with Down syndrome, and both parents, they were working as a daily laborer, and they are fighting, they are struggling for the guardianship at the age of 6 or 7 years old child, because the parents were not able to open the account for the disability pension, and they were struggling in the court system. So then I refer to them that please go to national trust, and national trust will help you after 18 years. Below 18 years, definitely you are the biological guardian, so I don't think you need it, but you consult with the national trust. So anyway, the problem has been sorted out, and this thing was the child was able to get the disability pension. So I mean to say that these are the system which is many ways there is lacking. And again, I'll say that assessment of decision making ability is very important in the psychological perspective, in the personal perspective, in the family perspective, as well as education perspective. So this is very important to understand, and assessment, on the basis of that assessment, if I am giving the choice, if I am giving the liberty to make the decision, definitely the child can be able to understand the capacity. What provision can be done? Two things are very, very important. First is supported decision making. Supported decision making can be implemented to mild to moderate. Everything I cannot impose, my decision cannot be imposed to the child. Definitely we have to support to take the decision. And substituted decision, which is initially in 1990 Canada used that term, limited decision making, and we can support to the child, support to the person for making the decision. Who can support? Definitely the parent, guardian. They are overburdened. Definitely they are taking care of the child, but they need to understand it. And rehabilitation professionals, there is a provision that we can, with the help of awareness, with the help of service systems, and community involvement is very, very important, and legal authority and lawyers, they can support that what kind of decision can be taken by the as a supported guardianship. So these are very, very important, and the future direction is we need to create model practice. I'll take 1 minute. Mr. Jolly and Mr. N Joshi both are national awardee. Mr. Jolly got the award, national award, in 2005 or 6. He is the winner, gold medalist in International Paralympic. And Ann Joshi is working, she is Down syndrome, 28 years old child. She got national award in 2019, if I'm not wrong. And she is working in a MNC. She has a very good decision ability. And this kind of practice we have to explore, we have to create. And assessment of mental capacity and decisional authority, that we need to assess it. And resources need to improve in terms of self-determination. We need to create rules and regulation. If I'm running a hostel, if adult person with intellectual disability is with me, what are the limitations and what do's and don'ts with me? So these are the things which need to cater for the persons with intellectual disability. And additional training, I have given my own example, because I was initially I was not bothered for the legal system because it was not my part, but repeatedly and regularly when I went to honorable court, then I realized, no, as a profession we have to touch this topic, we have to work on it, and definitely we need to do many more research in this particular this building legal capacity. Thank you. Thank you.
Thank you, ma'am. So we will take 1 or 2 questions for ma'am. If there are any questions or comments, the forum is open for that.
That was a really enlightening talk, and I think everybody must have gained a lot from the talk, and also be motivated to pay attention to something that none of the special people, special educators, and people who are working in this field are focusing towards. So, very, very enlightening. I have a couple of thoughts that I would like to share and actually ask Amrita ma'am about that. The first is that she mentioned about brain maturation and experience being a very important, playing a very important role in learning. Now, with special needs families, what happens we find is that they start off with a lot of hope, but somewhere they just uh, go into a shell. They move away from society and they start engaging with people who have either other special needs children, and they start having very, very restricted experiences. How can the whole community which is working with these people make sure that we are guiding them continuously to engage with the society, go out, go to different places, take out their children to different environments so that they learn and they are rich? Some of the families we work with, we directly work with a very small population and we guide the parents and we encourage them, motivate them. But I think it's a general practice that we need to have. What would you suggest to all the young?
Ma'am, before my presentation, Smita ma'am also suggests that stigma is one of the important factor which is responsible to restrict us. Not only the person with intellectual disability in our setup, many of the person who is lagging behind in some speech delay or something, sometimes only showing the simple temper tantrums the child is coming. So which gives me direction to give a brief about general awareness about the development. So we have to give, definitely we have to give orientation to the parent first of all, and parent to involve to make the significant involvement. It doesn't mean that whole day as a mother I'm staying at home and I'm engaged with the YouTube or WhatsApp, but I'm not interacting with the child. So just give some little work to the child at the early stage. You just feed something to take some sort of experience. Just leave some the child, if child is doing some mistake, just leave it and just teach them how you can correct it. That is the basic principle. There is no need to go for the big books and this thing. It's a very simple parenting. And I'll share one other example. One of the parent came to me. She was, of course, they are overburdened, they are anxious. They were saying ki whole day I'm staying with the child with special need, and if my child go to community park, everyone look at the child, and I feel very bad, I feel very shame, and I usually never go to that park or temple. I said that it is problem with you, because you have to go. If somebody is looking at you, just go and take care, and uh, definitely again you go. How much they can watch you, you just enjoy it. And after 10 days daily, the child is coming to school, and the child and the mother both came after 10 days. Ma'am, now the child has 2 3 friends. The child is playing in that ground. So that is the start from the less resources. Because once we will do the community orientation program, we will teach our young generation, this is okay, this is we do repeatedly we are doing. But first we have to give the confidence to the parent that whatever you have, don't feel ashamed. If you will feel ashamed, definitely the other will take it advantage in other way. So you have to confident and don't feel ashamed. It is very easy to say, but being a parent, constantly we have to. That is why cognitive behavior therapy and the some relaxation training and parent training is very very important. So as far as my concern, parental role is very important with the help of professional support. Thank you. I hope I answered.
Absolutely. I have a second point, and this is again from the legal perspective, that when a child is very, very young, let's say 5 years or up to the age of, let's say, 10 years, a diagnosis, a proper diagnosis, uh, mm, parents have started availing the diagnosis now because they want a disability certificate or something like that. So that is a very great role which is pushing the people to get a diagnosis. Now, the second part is the IQ assessment. Now, intellectual assessment is very important because just in case there is any mishappening at a later stage, and because you've been to the courts and dealt with that, how do you prove that the child has an intellectual disability if there's no IQ test which was periodically done, let's say at the age of 5 or at the age of 10? And we all know that that's completely missed out. Can the government come up with a similar rule like how they have for the disability certificate to get some diagnosis and at the same time ensure that there's an IQ test done?
And there is a provision in RPWD Act 2016. It is very clearly mentioned that below 6 years, the child should be, assessed with the, diagnosis will be global developmental delay or whatever. And every 5 years, like 5, 6 years, and then again 5 years, 5 years, and 15 years, and after 18 years, the final, certification process will be completed after 18 years. So it is very clear, but unfortunately, people are not aware, sometimes parents are not aware, professionals are not aware that it should be done repeatedly. Because of course IQ is not going to be changed, but the functionality, because the richness of experiences will matter a lot. So that is very much required to periodic, go for the periodic assessment. And it will give the, some kind of strength to the parent that they are spending money, time, and so many things. So what are the, status? But it is not recommended for the every years or every 6 months. Definitely, Act says that every 5 years they have to go, and the state government is responsible to provide the uh, um, disability certificate. They have to, create that system that every child should get disability certificate on time, and so that the any advantage they may take from the with that certificate only. Okay, thank you.
Thank you. I think that was a very satisfactory answer, and the responsibility shifts to all the people who work with the population to encourage the families, because we see a lot of families, they have no IQ, they do no IQ, they just come with their child. Many times they even have a wrong diagnosis. So if the child is on the severe spectrum, the diagnosis will be mild. So you don't even have a correct diagnosis. And this is going to have a real legal issue at a much later stage when the child is an adult. And if there's a problem, if there's no problem, wonderful. But if there is some eventuality where the child needs help, then these things are important and everybody should ask for it.
Thank you, ma'am. So now we have to break for tea. Before that, I would request Dr. Smita ma'am to felicitate the speaker, the participant. President Dr. Amrita Simon, please. Namaste. Thank you, ma'am. Thank you so much. And we'll break for tea. This
Our topic is disability assessment and community awareness. New innovations in assessment and management of disability. We welcome you, ma'am.
Good morning, everyone. I'm honored to be here today to make this presentation. I would like to sincerely thank the organizers and Dr. Shilpa, of course, for inviting me. And I'm very glad to meet several of you, new friends as well as some old friends here. So I'll move on with my presentation. I would just like to mention that I'm coming from a public health perspective, so my lens will be different from the previous speakers, both yesterday as well as today, because I'm looking at the community itself. Okay, so I'm not looking at the rehab perspective from a clinical aspect, from a service provider level, but more from a person or the population who is wanting these services and who want to absorb these services and move forward to have a very productive and meaningful life. So this slide tells us that when you talk about disability management itself, the first point I would like to say is that we have data that is, patchy, in the sense that there are many more people with disability than we think there are. That affects our service provision from the government side, from the NGO perspective, etc. Because we have 16% of the world population, basically 1 in 6, with some form of disability. Now, our national census will give a different number, as you all know, and it's sometimes talked about as though only 1 to 2% of people, the population of India, has some form of disability. So this is the first red flag that I would like to bring to your notice, that we have far more people with disability than we think they are, or those which are in our records. So the graph on the left side talks about by age group and type of disability, but the one on the right side with the blue spheres talks about the problems that people with disability are facing in each of the domains that has been mentioned there. So talk about education, employment, housing, access to transport, access to health care, etc., are huge gaps in each of those areas. But I will not go into that. I'm just talking about the management of disability has to, have all these circles in our mind. They have to be taken care of. The burden of disability in Telangana itself, from Sadaram, you all know this, you're all students. Many of you are students here, many of you are faculty here, so I will not go into the details of this. I was told by Dr. Shilpa that we would also have to make a briefer presentation, so I'll focus more on the management and the innovation in disability itself. I don't want to preach to the choir, you already know all these statistics. Legal framework, the speaker before the tea break, she gave an excellent overview of the legal framework. So I will not go into this right now. And just to reiterate that it is very important to have the legal backup in terms of management of disability and in terms of rights of people with disability. Looking at the innovations itself, you know that the National Innovation Foundation India is trying to bring out various innovations, trying to document things, the good practices that are happening. It talks about the value addition, the product development that is happening for people with disability. It talks about intellectual property rights. There is a business and development component in services for people with disability, persons with disability. And of course, there's also the IT aspect of it with all its the things that are happening well and those that need to be addressed. Some of the innovations that are here, some of you might be aware of this. So you have for mobility, for vision, and for other types of disabilities that are there. And the pictures are self-explanatory. I would like to mention that recently I was in a presentation where I saw a wheelchair, just a wheelchair, nobody sitting on it, and the wheelchair goes in various directions. Wherever there is a barrier, a wall, a chair, or a table, it just turns back by itself. So, which means that there are advances that are happening, and this is in Hyderabad, by the way. This is for persons with visual impairment who can sit on the wheelchair, and it will basically, with the use of artificial intelligence, figure out where there is an obstacle and then turn back or do a correction in the direction. So there are other innovations that are there. One of the things is a dumb sign system which gives voice to the person who is not able to speak. So when we talk, we have a lot of gesticulations that we do with our hands. There's a lot of emotions that are there on the face. And there are some systems that are trying to capture and make sense of both our hand movements, our facial muscles, etc., trying to read it and in real time try to explain to the person what this person is trying to communicate. Now, all these things are at the pilot level, many of them in India, some of them happening outside. But they are innovations that will hopefully change going forward the interactions that we can have with persons with disability and for service provision also. And the first dot watch braille smartwatch is also there, and some of these have been available in India and some are yet to arrive. More innovations, you must have heard of the iCane. You must have heard of another IIT Madras innovation where there is a smart cane, which again gauges the obstacles that are there and then does a course correction in terms of signals to the person who is using the cane. And then you have a braille tablet, you have a finger reader, and then you have a tap C. The various devices that are there that are trying to use technology for to make things slightly better for caregivers as well as persons with disability. I just wanted to mention at this stage that I have a neighbor, a child who I knew right from the age of 2, who is on the autism spectrum, and things were going fine in the sense that the parents were able to do everything for the child. The child is now 16 years old, and there are a lot of issues that the parents are finding difficult to cope with. And one of the things that is happening is this child is becoming, what should I say, much more vocal. So there are the mother feels that, again, as was discussed in the previous presentation, when the child is taken to various public places, there's a lot of sounds coming out from the child, which the mother feels that the others might think or look at him differently, and she's not comfortable with that. So I see that child who used to be playing around with everybody now going into the shell along with the parents. And this child is a upper middle class family, very well acquainted with technology, has a tab, has a smartphone that he always is around. His classes and rehab also happen with the smartphone and the tab. What I'm trying to say is that this is one end of the spectrum, but there are others who are on the other end. So you might ask me, okay, all these fancy gadgets that you're talking about, are they accessible to people in India? If they are, what are the costs? What is the implication for a person who is a daily wage earner and has a child with disability? How does that person access these things? Now, I do not have answers to all these questions. Those questions are also within me. But going forward, I think that there will be improvements in access. So this is more like a thought-provoking thing that I'm talking about right now, with no real answers or solutions at this stage yet.
but hopeful that things will be better. So there are other, in terms of innovations, that's what my topic is. In the assessment and management, we know that, especially for women with disabilities and children with disabilities, in terms of their attending school, their access to various services are very, very limited. So some of these might help going forward. So there is text to speech assistive tools that are there. There are different graphic organizers. I am working with a person who is entirely visually impaired, and she is a PhD student, and she's constantly emailing me about, ma'am, this is the proposal now, how do we go forward? And everything that a person who is interested in research and who wants to make a name for herself, she's doing it. Only thing is that because of her, condition that is there, the visual impairment, we have a feeling that, okay, will she be able to, use all the facilities that are there for a person without visual impairment, and will she be able to make use of all these things in the right way? So I'm hopeful that things will work out well. So there's also hearing assistive technology, and then for children with sensory neural hearing loss, there are different sound systems that are there, and different mechanisms by which, children and caregivers are with various types of disabilities are able to take some of those technology innovations and use it. So if you look at, one of the major issues that is there, you will agree with me that people without locomotor or physical, the issues that are there in crossing a road, it's so difficult to access transport, to access safe roads. So persons with disability, it is even more difficult. So there are some innovations there in terms of accessible taxis, or a lower floored bus that is there, or some train systems that we are having now. But this is a drop in the bucket. It is still, it assumes that you are able to get to the bus stop, you are able to get to the metro station, and then the floor of the bus is slightly lowered. So all these assumptions about how do you get to the metro station, how do you get to the bus stop? So those issues are still there, but there are some innovations nevertheless that things are better now. Looking at some of the app-based innovations that have happened, there is a stroke care app that was developed by Dr. Suresh Kamalkannan of our own institute, and it's a very easy to use kind of application, which I have used myself. This is for stroke care. I used it for my mother when my mom had a stroke, a really difficult one that finally she could not survive the stroke. But the exercises that are there, the rehab part of it that is there, is very simple to follow, and it is accessible to anybody with a smartphone. Again, assumptions here: how many people have a smartphone with enough memory to have the app installed and use it regularly? But there are innovations in spite of some of the obstacles that always go with a technological initiative. There are others in terms of assessment of disability. Some of you may be familiar with this. For example, there is accessibility assessment for built environment India. There is a framework as well as an easy assessment tool that you can use to assess if buildings are accessible or not. One of the things that we did from the Indian Institute of Public Health is to look at 110 buildings in Telangana and see the accessibility there. And I can tell you that there was not a single building which scored on all the components of accessibility, not one. But that was used, of course, for advocacy as well as making them more accessible in various areas. So there is a rating system kind of thing which is used for assessment. And there's a specific learning disability assessment and interpretation by, okay, thanks, from the NIMHANS Bangalore. Again, I will not go into the details of this. There are innovations in assessment of disability. and some of you might also be using them already in terms of the Indian scale for assessment of autism. It's an objective assessment tool, and if those who are not familiar with it, please take a look at it. It has a scale which you can use to score on 40 items. There's also, sensory assessment and rehab for visual impairment. As I said, this is an app-based thing as other tech interventions that are there, but you people are already from the clinical side and you are already using some of the assessment tools. But you might want to consider that there are both paper-based, app-based assessments for dyslexia, readability assessment tool, etc., etc. There are lots of initiatives that have been launched by the central, state, and NGOs. One of them is Badhte Kadam. It aims at community awareness, etc., but for sensitization and to increase the representation in remote areas where the national trust is underrepresented. Other initiatives that are there, you already know this unique ID that is there. There has been an intervention from the government of Gujarat for service provision, and then you have the Accessible India campaign mobile app itself, which can be used to upload pictures, etc., for places with less accessibility. Disability-oriented innovations that are also there from the Center for Innovations in Public Systems. Again, there are various focus areas and various areas of operations, but this just gives a snapshot of the interventions that have been happening from SIPs. I'm almost done, the last slide here, second last actually, to show that there are several gaps, some of them that I briefly alluded to, but there is a need, both from the national data, which I'll talk about in the next slide, and also in terms of training needs, trained people, gaps at the policy level, gaps at the legal level, and funding and affordability of various technologies. One is access to technology, the price, and will technology really change things and how will it change things? So all these are still burning questions that are there that we can, that is food for thought. The last slide I would like to leave you with is coming to lack of data. We have information, but they're in piecemeal way collected in small surveys, etc. Nationally represented data that is comparable across countries is still wanting. The Disability Data Initiative that we are a part of is happening in 184 countries, and there are reports of the disability data that from 2021, 22, as well as 23, which we are working on. One single sentence summary that I would like to say is, in India, we do not have the nationally comparable data that's there. We have 8 regional teams. I cannot compare our data with Sri Lanka or Colombia because what we are measuring is different from what everybody else is measuring. So that is a big gap. So we have data, but nationally and internationally comparable data is missing in terms especially of the functioning element of it. How functioning is a person with disability? How do we compare it across age, sex, disaggregated, across countries or regions? So I'll stop there. Thank you very much again for this opportunity. Here are some references, and I would like to also place on record my acknowledgement and thanks to Dr. Sara Jamil from Indian Institute of Public Health, Hyderabad, who helped with the slides. Thank you.
Thank you so much, ma'am, for throwing insight on the disability management and innovative devices as well as assessments. As we are falling short of time, we are moving ahead with our next presentation. Our presenter is Dr. Shilpa Manogna, ma'am, faculty in NIPID, and the topic is Disability Solutions and Rehabilitation Models by NIPID. Welcome, ma'am.
Very good afternoon to all. And I'll be briefly discussing about various disability solutions and models of care, which as a NIPID, a National Institute, has tried to evolve over the 3 decades of time. And I'll be very quick enough in telling that NIPID was established in 1984 with 3 regional centers in Delhi, in Kolkata, and in Mumbai, and we also have 3 composite regional centers in Karnataka, in Chhattisgarh, and one in Nellore. So, this is briefly about the objectives of NIPID, and NIPID tries to fulfill all its activities which would fall under this particular objectives. And I'm giving you a very quick overview that in the year 1984, when there were no standardized HRD programs or any human resource development programs in the area of disability, especially in the field of intellectual disability, NIPID was first to design the curriculum and bring out the programs which were later replicated and standardized by Rehabilitation Council of India. So we were very active in initiating 9 courses which were ranging from diploma to MPhil level. And one of the important objective is development of models of care. You can see that NIPID has always been focusing on providing appropriate rehabilitation services for persons with intellectual disability. When I say persons, it doesn't mean that only the client is important to us. We also give equal importance to the family, because the family, until and unless it is empowered, we strongly believe that the child would not be falling in the line of that rehabilitation process. And then the research and development. So we'll quickly go through the other objectives. So these are the HRD programs which have been initiated by us, and I'm very happy to announce that very soon we are going to initiate PhD in rehabilitation psychology, PhD in special education, and also an integrated BSc B.Ed special education, which would be in line with the new NEP policy. So these are some of the things, because we feel that all right now the PhDs which are given in the country are mostly PhD in the education, and the topic is there from from the area of special education. There are only 3 or 4 universities which are offering PhD in special education. So this PhD in special education will be totally focusing on IDD. So every year around 500 professionals are undergoing various long-term courses, but still we feel this particular thing is not yet enough for the huge population which India has, and all of us have been hearing about the increasing prevalence of disability, and now that we have 21 disabilities, I do not know how alarmingly high these numbers are going to be, when actually there would be a new round of disability assessment and the prevalence which will be done by the concerned authorities, be it NSSO or whatever. Then rehabilitation care models, we absolutely follow a life cycle approach and have come up with the very first kind of early intervention services, which was rolled out somewhere in the late 90s. And looking at that particular model, which was already existing, the ministry has decided to start cross-disability early intervention centers across the country on this particular model. And that model which was there, we had to refine it because there were a lot of advancements. And under the aegis of the Ministry of Department of Empowerment of Persons with Disabilities, total 17 cross-disability early intervention centers have been established across all the 9 national institutes and the CRCs, and we are expanding it more to our regional centers also. So the major idea of this particular thing is that no child, no matter what is the category of disability, is at risk or already identified as disabled, should be able to get the necessary services all at one place. We are strongly saying that we do not want the parents to run from pillar to post to get the appropriate services. So all services under one umbrella. And then the preschool readiness program, the special and the remedial education programs. And this is something, the one which I highlighted in the red is what I wanted to focus, the family cottage model, which is exclusively developed over here, that where the family as an entire family would come, get all the comprehensive assessments done and how to manage. They would be trained over here in the family cottage and at a very, very, affordable price to stay in the organization. The respite care model, we have, Shailaja madam, who is the brain behind this respite care model. She was the one to initiate this. This is to give to the parents a little relief and respite when they have work of their own where they have to leave under qualified and trained educators and professionals. The children with intellectual and developmental disabilities can be, left here in the respite care center. Earlier, it was a 24 hours service was given. Post COVID, we have made it into the service is being offered only till 5:30. We are not offering the night service in the respite care. So happy to see that almost all 3 lakh people were given support services across the country in the last year through all our regional centers and all. But again, we feel that there is a very, very huge gap in the number of services which the parents and which the clients require. There is a need, still there is a need to plan and devise an appropriate mechanism where parents can avail these services without much difficulty. So, R&D, I'm rushing through these slides. You can see the gap here itself. Most of our research is action oriented. We have to critically analyze ourselves in order to progress. So I feel that this is a gap that we have, longitudinal studies are very less and it's more sort of action oriented research which has been focused. Initially, it was to create a lot of awareness because there was no awareness, and slowly we moved to the other areas. And now technology has, after COVID, technology, before COVID also technology was there. But I think the way we have embraced technology after COVID is remarkably different the way we embraced technology before COVID. So that is also our, an area where we have to still focus. You can see we only have 3 research projects which have totally focused on that. Now it is the need of the hour. So need-based solutions, a lot of awareness manuals, parent training modules, screening schedules for all the learning intellectual and learning disabilities, assessment tools, indigenous assessment tools, which are developed here in India. Most of you might be knowing these tools, and some of you who are new into the field or might not have heard about this, but probably this would be an opportunity for you to see. And also assistive technology and learning tools. So we have Isadia, yesterday we had it. Apart from that, along with CDAC itself, we have developed Swar, a mobile app where people with autism and intellectual disability will be able to use that app to communicate their needs. Okay, this app is also, very, very useful for the communication thing. I know there is, scope of improvement in everything. We need to revise and, modify it to be suitable for the current day scenario. But this is also available. Yes, again, one more, need-based solution. Many of the teachers, before COVID and during the COVID time, this is a very pressing issue whenever we talk with the professionals, that professionals would say that, we do not know how to go about it. We want to train. So this is what we have done. Department of Special Education has carried out a small research project and has come out with proper sexuality educational assessment checklist. So the teachers or the professionals who are working with young adolescents and adults can start, in a scientific way, assess them, identify the needs, and provide the need-based sexuality education, which is very important for our children. And then there is also a pictorial guide. So it gives the all the activities. It's like a curriculum which can be followed in the school in the vocational training setups. So the lesson plans, the materials which need to be used, the picture cards, everything it comes as a package. So anybody would like to work in this particular field, it can act as a starting guide, and then there is a scope for improvement. You can give us a feedback that what has worked and what has not worked with your students or with the clients which you are dealing with. Apart from that, TLM distribution, teaching learning material distribution, under the IDIP scheme, like every disability has one or the other kind of an assistive device. And when we were going through, like what can be given for children with intellectual disability, then absolutely there was nothing. Okay, locomotor disabilities were getting crutches, wheelchairs, tricycles, all other kind of non-assistive devices for improving their functioning and all. Then the vision impaired were getting smart canes, talking watches and all. It was the only group where there was absolutely nothing being provided. So this was designed again, teaching learning materials, which is given free of cost to all the eligible beneficiaries under the EDIP scheme, and we are the nodal agency. And this is not just compilation of it; it is the result of our research project, which has been undertaken by the Department of Special Education, and many across the country. These TLM kits have found their way and especially it has helped during the COVID time, because this is the time when children have not gone to the school, and these kits are very useful for the home-based education and intervention. So these are some of our new innovations. Yesterday you must have heard the community-based mobile rehabilitation services under the Hans Foundation, a mobile screening app which is in collaboration with the Ministry of Women and Child Welfare. This mobile screening app is being developed for the use of Asha and Anganwadi workers in Telugu to be used in the state of Telangana. Then Shishu Vihar, which is again in the under the government of Telangana, we have established the primary rehabilitation service center over there. Similarly, in lines of it, because Shishu Vihar is an orphanage, and children were having difficulty to come and get the services. So we established the center over there. Then a video-based skill development module, which consists of 10 videos for giving vocational training for individuals with intellectual disabilities. Then a comprehensive vocational assessment tool, which is following the NSQ module and is aligned with the Skill Council of India. That is also has been developed. Then animated films. Yesterday we have screened it here in the auditorium. Then we are in the way of coming out with an Indian test of intelligence. We are very shortly going to come out with this particular thing. The data analysis and the report writing is in progress now. And one more important thing, because always the parents will come and ask, like, what happens to us next? Yes, National Trust has come out with it, but that's not the only answer. So we have started a residential facility called as Matruchaya for all the, I should say, for the army personnel, those who, the army people who lost their lives during their service, those children, where would be they kept and who will take care of them? So this is the facility we jointly started under the TASA, that is Telangana and Andhra sub area. It comes under the administration of the Indian Army and the military. So Matruchaya, a residential facility where exclusively, I'm not saying this is the answer, but this is, an initiation where people are being taken care using a standard protocols, and we were instrumental in starting this particular thing. So networking and collaborations with all these government agencies, a lot of short-term training programs for all the stakeholders, and the gap finally, not saying that we have achieved everything. Critically, if we see, we are still to work a lot in creating accessible environment. Somewhere we are a little behind this.
education and employment, although so much is being done, still we see that children with intellectual and developmental disabilities are not finding place in the regular schools. They are being denied. I know RTE is there, everything is there, but still parents come back to us saying that they are not accepted. So that means somewhere something is not working, and we are trying to analyze that how best can we fill this particular gap. Training of human resources, there is a dearth again over here. Then standard service protocols. This is again yet another thing which we are strongly, and I really want all the professionals who are here to come and join hands with us and help us out in sharing with us what protocols are working good with you, what is that you are following, and what standard protocols should be announced by the government, that no child with disability is treated ill treated or mistreated, or disability is not a money making business. Whatever treatment, whatever interventions we are giving should be standardized procedures, and parents should not be misguided about any kind of a treatment or any kind of an alternate intervention treatment which is not evidence based. That's what I wanted to highlight. So that's there is a definitely a great need to come up with standard service providing protocols. So that's all from my side. Thank you.
These were two very beautiful talks which not only looked at or informed us about what is happening, both in public health as well as what NIPID is doing, but also they had this slide with a lot of areas which are still lacunae, where there are gaps, and that awareness that we have to fill these gaps is the first step to development. So I would like to congratulate Dr. Shailaja and Dr. Shilpa for the brilliant presentation that they gave. On behalf,
Requesting Shailaja ma'am to come onto the stage, please.
I just have one request on behalf of all of us, that any planning for the disability sector would happen with data, and we don't have data. We are guessing all the time. Every presentation says that we are guessing that it's so much percentage. If we know what's the percentage, we would request public health policy to look at data. We really don't have the census, and that's a very big gap we face. So thank you very much with that.
Now we are open for questions. One or two questions, please.
Thank you, Dr. Smriti Awasthi, for raising very pertinent areas that we need to consider. And I congratulate both the presenters for the wonderful presentation. There are 2-3 things I would like to share in this forum. It might stimulate some positive and productive measures that we could go in for. First to Dr. Shailaja Tetali and also Shilpa, because both state and central. Can we have models where we can demonstrate the available assistive devices which can be used for daily living of persons with disabilities? In fact, I'll share one. Probably a lot of people must have received this on the WhatsApp, but in Chennai they have started one, and we used to have it in Adi in Delhi under National Trust, but that has been dismantled now. So the one which has taken a substitute place now is the one in Chennai, which everybody can have a look at it, which has now currently been inaugurated last week. And it was inaugurated on not last week, on Autism Day. 2nd April. So can we think of having such examples for parents to understand what is the functional use, what is the validation of it, what kind of facilities need to be provided if it can walk into their houses? So the individual who's going to use it and going to improve the quality of life will actually be integrating it with his lifestyle, his or her lifestyle. So I would request the state and the central, because National Institute being in Hyderabad, doesn't matter even if it's duplicating in the same city, but it is worth, because you have a OPD section or the outpatient section here. A lot of parents come from all over the country. I'm sure it happens at the public institute also. So please respect every parent who can access it from that point of view. Don't say 2 centers are in Hyderabad. That government attitude, please get away from it. Second, most important, have a checklist of all these available materials and the producers, manufacturers. Can we give this information to parents or put it in public domain so anybody can download it from maybe your website or wherever you think is apt, even in our services section. So, and give it to all the people who are offering services. Wherever the cases are being taken care, I think it should be displayed somewhere. This could go in terms of disability category wise, even if it is not intellectual disability, if it is for other disabilities, no matter, because we have combination, we have multiple conditions also. So everybody can have access and they can choose what they want. Third, most important, can we have training programs at the state and at National Institute with all the disability commissioners across the, if possible, in your state first to begin with, or with other states, how we used to have, I remember in the earlier days, we used to have, rapport with the state commissioners and we would have training programs. They would recommend what level of functionaries can be further supported. What happens is in this kind of interaction, you will get a lot of data which is being collected by the states. Do not say data is not there. We are not reaching out to the right people. This is what my feeling is. Every commissioner gets the data from the additional directors. And that pool is there. That is how they project the budget. So we need to have these, conversations, dialogues, and collect it from them. I'm sure they'll be very happy to share it with you. In fact, I'm pushing it with one of the states right now. But because it is not a model, I'm having tough time convincing why this is necessary. If National Institute can initiate this, then people will have confidence in this mode of communication. So these are 3 important suggestions I wanted to share with the panel here.
Thank you, ma'am. We have, we'll try to work on those suggestions. Just to add on, with the dialogue with the state commissioners has already started, and we have conducted 2 workshops. Two workshops on various aspects of disability, one in Indore and one in Ahmedabad, where all the state disability commissioners and the directors who are dealing with the disability department were sensitized on. Yes. Yes. Yeah.
Thank you, ma'am. Very useful comments. I just wanted to respond by saying that data is there, but it is patchy, as I had mentioned. It is piecemeal and patchy. But the thing is that we need also internationally comparable data on standardized, indicators. That's the part that is missing. The other. Yeah, exactly. So the thing is that I would also like to mention that, the sensitization of commissioners, if you look at what they want to see, I think, in terms of what works, what are the best practices that have worked at scale, not in a single, kind of example, but they want to see what works at scale. And that is the kind of evidence that needs to be generated for larger policy implications. Yeah, that can be a start. Yes. And then what we have to look at is any interventions that have happened. Who is evaluating them? Yeah. Who is evaluating those interventions and what has come out of? Exactly. But the thing is, ma'am, also for success stories, we will need those indicators that we can compare across for other. Right, yeah, that compilation is necessary. I agree. Thank you.
I now request Dr.
There's one question. Okay.
Not a question, but a reflection on the two excellent speeches that I heard just now. So, both from a mental health perspective and from a public health perspective. Uh, there is this whole challenge around how do I get my child to access, for example, a park or a community services? How do I have the child accepted in the society? I think that's where professionals play an important role because parents are not very well placed. I would say they know their children very well, but they also have over a period of time withdrawn, avoided. They don't like the stairs, and so there is a kind of a barrier between them. No, society, I would say, is willing to help. Definitely, there is this uncle, there is this cousin who really loves the child, but the parents don't know how to take their help. There's no, so if we are able to facilitate some interactions at a micro level, of the child, the family, with a larger, if I start with their immediate relatives maybe, and then maybe some volunteers from the society, a neighbor in the building, and tell them how to interact in a healthy way. It should not be antagonistic. Sometimes I have seen, so how to interact in a healthy way, and then also tell the society how they can help these families. If we have some thoughts around that, we are able to work with both the groups, then I think a great stride can be made. So,
Thank you so much, sir. I now request Dr. Smita Avasti ma'am to felicitate Dr. Shailaja Delatadi ma'am.
Please.
Sorry, sir. Sorry. Yeah, please, sir.
Good morning. With our Shailaja Madam's words, I just want to request submit the commissioner. See, with the point of parents and the parent point and the child point, if you look into that in our state particularly, in other states also have been in almost 22 years in different part of the country. With the recent act, as per the 2016, there is a clear-cut instructions to take every child with disability to regular school. But I don't know how it is missing out when we try with the parents to take to the most of the schools. Schools are immediately the saying that this child with this reason we cannot take. It was one. The second point of it, lot of states saying that for the best practice is that we want to give in Telangana Sadram certificate, another state different type certificate with the database. It's an excellent plan and project is excellent. But fortunately, what happens is because of these reasons of database with the recording and all, most of the time, even in the last 3 months back, if you see after 2022 November to till 30th of January or 30th, 3 months, there has been no certification has been provided in the state of Telangana just because of Sadram. The system is not working. The certificate has rejected, and most of the children, because of that, they are not able to get any services, any benefits. These are the simple thing, but when come to the point of the parents and the children, it makes their whole life is a miserable. Whole life is a very horrible thing. And in addition to that, there are issues if it's a very simple, but it looks sometimes very bad. I personally felt it. Last 6 years, the awards has been given the central government and state government on the day of persons with the International Day for the Disability. But unfortunately, last 2 3 years, most of the state, the intellectual disability who are a role model, very extraordinary sports persons who got a international awards, they have been not been facilitated. All other disability, whenever we go, I don't know today's situation and circumstances. If I study, if I look into that, the intellectual disability or developmental disability is increasing like anything. All other disability going slowly coming down, coming down. But in the facilities wise, I try to submit this. The intellectual disability with our own best effort, we try to give 2 3 awards this year. But 3 years, the intellectual disability who have made a best effort, they are not got the award in the state, most of the state, and particularly I can say this state also it happens same thing. My submission is that when we do things for everybody, please consider, please include autism, intellectual disability, and all development disability. There little bit the minimum talent should be supported, should be recognized with all other disability. That is one of the concern which I see When we work with these disabilities, they have been most of the time lastly seen. They may not even considered at all. And award has been this year with the fighting with the disability commissioner and all, we got 1 or 2, 3 awards. But last 3 years, for put the application, no recognition, no awards. But other disabilities, they are very easily getting, particularly locomotor, visual and all, because they are talkative. They are able to put their voice. But unfortunately, the children, the persons who are not able to put their voice, it has been neglected. I request, please consider this. Please support all the disabilities and particularly this developmental disability because they are voiceless. Please don't neglect them. Thank you.
Thank you, sir. I now
Sorry, I know the concern about that time, but
No
I
issues,
could
no
address
issues.
this myself without asking. I might not get another opportunity to ask the experts. I would like to hear from Shailaja ma'am. Before that, I would like to tell about myself. I did my PhD in social work. Right now, I'm into the tech world where we are actually developing apps and other things. And fortunately, my wife is here as a student, and that's why I came to know about this conference, and that's the reason why I'm here. Now, my concern here, we've been talking about the data, we've been talking about the numbers. I, of course, understand the need of a generalized perspective, or generalized programs which can actually fetch numbers. Like, we have this much problem, we have delivered this much intervention, or this much people have been, they've been supported, or they've been helped, or they've been gone through intervention. I can understand that. But on a personal note, when I see people from the very limited resources, there is an element of qualitativeness. Like from the community health perspective, from the community as the person who knows the community well, how are you addressing the variability? We are talking about the general conditions. These are the general conditions. Those are supposed to be addressed. I understand that, which gives a number to us. But what about the variability? What are the specific interventions, or how are we going to address that? As a professional, there are a lot of people coming in front of you. They might be having very variable issues with them, even though they have some general set, but they have their own specific issues. I'll give you one more example to make it clear. Uh, as a counselor, there are people coming to me telling me about their children, that they are suffering from so and so. What will I do? I have heard counselors, mental health practitioners telling them have good time with them. That's one solution. But what is the specific solution? How are you going to address that specific thing? We say that it is commonsensical. We give them a time, give your children time. But I put it in a different way. You call happy time, let it be 17 to 15 to 17 minutes. You do your exercise. Similarly, you devise a time in your family which is called to be as happy time. That time you are not supposed to use any gadgets. Be with your family, sit with your children, see how they are behaving. So that is one specific thing. I am more worried about that specific nature of being with human and intervening with them. So, what is your perspective on that? Being seeing a lot of people in your career, how you manage that variability? Not talking about the numbers, but what about the variability?
Hello. Thank you for that question. I would, you know, I would like to respond quickly by saying that the variability is an issue, obviously. But the thing is that, again, I would like to first clarify that I'm not from the clinical perspective here. I'm talking about the public health perspective. We do not do rehab or assessment on a daily basis. Okay? So we're looking at the larger perspective from the community health or population health kind of perspective. So variability is an issue with data collection in various fields, including in public health, including for persons with disability. The way to address that from my perspective is we look at large surveys that are there, which, get data on specific questions and fields, and so develop indicators for that. But that will capture, on a large scale. You're talking about the smaller differences that could be captured between people and things like that, and variability you're talking about. For that, they will generally use a mixed method kind of research where you will get the nuances, you will get the layers that are there from a smaller sample of people who are using devices, or who will provide inputs for further refining the kind of usability that is there. That's the first aspect of it. Now the second aspect of it, how do we capture it? And going back to Shalja ma'am's question before, saying that best cases, the case studies, use cases, and success stories have to be captured from an individual interaction, right? So you will have then a combination of larger kind of data as well as the smaller pieces that will have to be triangulated and then only used for recommendations or for evaluating interventions and things like that. Quickly for the second one, absolutely important to have the happy time that you're talking about. And I think each family is actually grappling with the same situation after the pandemic and still going on, where things have changed quite a bit in various spheres of life, including the quality time that we spend with each other in the family. So I suppose that is something that we need to devise on an individual family kind of situation based on the realities that the family is facing with, because this is not the only, the child with the disability is not the only thing in the family. There are several things that are going on, and there is an intersection between various things and issues in the family, right? So I will just stop there. I don't know if I've answered your question, but just a few thoughts. Thanks.
Dr. Sharja, can I just make a comment taking it from there? So basically what you are mentioning here is a molecular approach. Okay. Now, public policy is a molar approach. It is like looking at a very big picture. When we look at our field where we are working with special needs, what kind of research and data is coming? Mostly it is small numbers. We are still not doing RCTs like how they do in the medical field. So we need to do research. Even success story, if there is one success story I tell, it's just one success story. So if we want to say this protocol was developed or this app was developed and this is what the success story over there is, large numbers. Okay, till then nobody is going to listen. Just to give an example about why nobody would listen is, I have one of the largest studies in the world, longitudinal study on non-vocal children with autism. It's published. I got my PhD with that. Okay, 126 children participated. Out of those 105 were selected, and 83.7%, 83% children who were non-vocal between the ages of 1.5 to 13 and a half, 83% got vocalized. They got their vocals. Vocals were not perfect for everybody, but they were vocals. They were able to say bar for ball and ka for car or whatever. Okay, a various. How many people in India know about it? Not one. Except for a few people who work with us, we collaborate with. How many people? Nobody knows about it. There are protocols we developed, and those protocols we have been following for the last 13 years. They show results, so we do it. So molecular approach and molar approach has to come together somewhere. But if those people like us who are working with them, all of us are working with individuals, until unless we collect data and collect larger and larger data and give it to NIPID or some organization and say, this is what our data is saying. Okay, have a look at it and collect data from other people. Till then, nothing is going to happen. Yours, all yours.
Yeah, in line with what you said just now. In fact, for state of AP, I'm involved in it, so I'm sharing that experience, which I'm planning to take it up with Telangana also shortly, because I saw the GEO that has been issued for 21 categories. Autism is missing in it. That is the problem. That's why the children are being given a wrong certificate of ID. ID children are not eligible for educational benefits in regular schools because of their default nature of disability of having lower IQ. So this is where it bars them. This is the implication of giving a wrong certificate. So the child needs it, but because there is no system that records or registers the indicators, the child is deprived of that recognition. Now this is where the problem is, and we professionals have to solve it. We can't sit here and say, let it happen. It will not happen.
Another 100 years, you'll be in the same situation. So the choice is ours, and we cannot put the blame on anybody else. We are responsible for it. So what I had suggested to director 2 days back when I spoke to him about this issue, because what happened is in AP, the file was submitted by the director disability to the principal secretary, and then the principal secretary kept on sending it to different departments to consult them. This is the process. That's the protocol. We have to follow that. Since November, the file has been going, but no remarks, no feedback, no action plan. The file is roaming around. So when I came to know about it, I said, we had a team which we worked in 1995 when 7 disabilities were benchmarked under the Act. And I remember NIPID, then NIMH, all the departments, all the HODs sat together with the Disability Commissioner, and then Umatuli Madam came here. She was the Chief Commissioner of Disabilities then. She also joined us, and then we drew the parameters how the certification guidelines have to be issued. So for 7 categories, we did it in 1 month. I remember that. I was a member in that. So I shared that experience with the Director Disability. I said, why? It's been 7 years now, the Act has come into, and till today, the children are not entitled for what they deserve. So a child who was born in 2016 is 7 years old now. We've already deprived the child of recognition at preschool level. Now, in future, if you want NEP recommendations to be applied, the child is not because he's not recognized. I mean, what is this that we are waiting for? So what I'm trying to say, Shilpa, is work with manageable in terms of geographical proximity. Work with those administrations whom you can work with and you can follow it up. This becomes a model for the others to follow. And you can probably come up with a better method of sharing and replicating the model. So you've done it in Ahmedabad and somewhere else. How do people in Hyderabad get to know where National Institute is located? So don't you think it's impractical to give that feedback? So what I'm trying to say is, don't go straight by, because already we have wasted 7 years after the Act was introduced. And in Delhi, they issued, I have a photograph which Shefali Gulati has put on the post. The certificates for autism were issued in 2017 July. And when was the Act declared? It is 16 December 2016. When it can happen in Delhi, why can't it happen elsewhere? So how did they work? So why children here have to suffer for 7 years? This is my question. Don't you think we all need to answer this? It's not a matter of something we can delay it any further. We need to have an answer, whatever small way, whatever humble initiatives, but please begin the process. Here, my worry is the process has not yet begun. And it will take time to build up. That is my worry. So please, if I'm aggressive in my narration, it is because of concern, not anything against
ma'am. We understand that the process has begun and the trial run is in process with the state government. Somehow the trial run is taking some time. I know it because the disability department is, and we are working closely to come up with all the standard procedures to issue the disability certificate in Telangana. And afternoon we have a representative coming from the government of Telangana to present on the same aspects. There is a session also on that.
We are responsible for the subcategory of intellectual disability.
Yes, ma'am. That's the same thing.
At least for those 4, our institute can work.
Yes.
The other, we leave it to the other departments concerned. But we can do it in that area, no?
Yes, ma'am.
Then what are we waiting for? That's all.
We'll try to, take it in a much more aggressive way.
Not aggressive.
Yes, ma'am. It sometimes requires aggressive approach to solve the issues, ma'am. Yes. Because until and unless some authorities would not come and fall in line and take the procedure forward.
Okay, we are falling short of time. That's why we are not going to take any more questions.
Good news is AP has declared the GO yesterday. And today we are already fixed an appointment with the collector to launch it in Karnal State. So this is what we need to do. That's all I'm saying.
Yeah, one. Be short. Just a single line question.
Yeah, and this is for the team, whole team. Actually, we are from LBPI and we are sending children with multi-disable children and they have a severe visual impairment. Do we have a IQ test for visual impairment? Because they have a contrast sensitivity issue and they have a visual field loss and they have a central field loss. Do we have any specific test for IQ? And we are keep on getting certificates. They are saying that they are intellectually disabled because of lack of tools and lack of awareness. And the tools that what we are using for normal children and intellectual disability, we can't use for children with visual impairment. And one more thing, we have a Sadaram facility, and there they are not considered visual field as a parameter, even though in RPWD Act 2016, they should consider, even they don't have equipped materials to check visual field. They have a central vision is perfect 6 by 6, but total 100 per 100, we have a 180 degrees of field, it's zero. They can't do at simple daily living skills on their own. Still they don't deserve for the certificate even though they have 100% loss. So just to information.
So much for the question. And yes, we do have different kind of tests like verbal test, non-verbal test, performance test of IQ. And depending on the child's need and concern, we decide whether the child is able to do performance or not. If he is not, then we go for the verbal test. And there are a number of tests which are available and we do it in the NIPIT. Right. Thank you.
So we are going to end this session. Before ending this session, I request the chairperson to felicitate the presenters. So. Thank you so much. So. So we are falling short of time. We are supposed to have a parallel session presentation before lunch. So we'll be having that parallel session presentation post lunch, but the lunch break will be half an hour, not 1 hour. So you have to have a quick lunch and come back for parallel sessions. Like parallel sessions will be happening in three, one here in auditorium and other two in two conference halls. So I'm requesting everyone to go for lunch and come back by 1:30. And those who want to interact with the experts, they will be available around the dining area, so you can interact with them during the lunch hours. Okay, thank you so much. Be quick for lunch and come back fast.
Our first presenter for this session will be Dr. Ravi Prakash Singh, effect of animated films for creating public awareness about disability rehabilitation. We welcome you, sir.
Good afternoon, everyone. I'll take the opportunity to introduce the first speaker, Dr. Ravi Prakash. Ravi Prakash is faculty, lecturer in special education. Currently, he is posted in Regional Center, Navi Mumbai, and he's associated with NIPID since 2008. Am I right? 2008, and before that, he used to work as a special educator and faculty in various other organizations. He is very creative, and he developed that animated film, which is very important to understand all of you. So all the best, Dr. Ravi.
I would also like to add some more information about Ravi's unique qualities. He is interested in UDL, and anybody wants any good guidance on UDL, you can contact him after the presentation.
A very good afternoon to all the dignitaries on the dais and off the dais. It's a great privilege and honor for me that to present the today's research paper in front of my guru and the chair of the session, Selja Rao ma'am, and my senior colleague, Dr. Amrita Sahai ma'am. Coming to the topic of the study is effect of animated film for creating public awareness about disability rehabilitation. These are few keywords. Basically, when we talk about awareness, it is always an issue. Earlier it was there, even today. It is, we can see that the public awareness about disability and different issues is very low, and which directly affect the services, which directly affect the rehabilitation process. So, disability awareness, a program conducted primarily through rallies, skit shows, and other medium, which is having a very limited reach of public, looking at the number of population of our country. So even UNCRPD has said that awareness is a key area and immediate, effective, and appropriate measures needs to be taken, and measures that will include initiating and maintaining effective public awareness campaigns designed. Our RPWD Act also says that the awareness, it is the responsibility of government to look into the awareness through various television, radio, and other mass media which we can use. United Nations has stated that the media can be only vital instrument in raising awareness, countering the stigma and misinformation. And this we already witnessed that before the movie Tare Zameen Par, hardly people know about dyslexia in the country. Once it came, then it created a mass awareness and mass impact. So, keeping in view, NIPID has undertaken a project of development of animated film, which in which I was the principal investigator, and co-investigator was our former faculty, late Dr. Mosmi Bhaumik madam. So, a question arises: why animation as a medium to create awareness? So, basically, we want to focus on edutainment, means education plus entertainment. Ethical issues are also related. If I am using some videos where photos should not be displayed in public, so then animation is a better option where ethical issues may be taken care. Some concepts are non-visual in nature, like if I ask about digestive system or breathing, then I can easily show that through animation. It is more appealing to the audience, as well as it fit to all age group. Earlier we thought that animation is only related with children and kids, but now every age group we can see that they enjoy the animated film and visual effects also. So in this 5 videos were developed: causes of disability, prevention of disability, which was displayed during the before the inaugural session. Early intervention and identification, inclusive education and vocational training and rehabilitation. There are a lot of review of literature which is there in the country and outside the country. So one of the literature says that role of media and community awareness towards rights of person with disability, says that media is having great importance. Then also now a recent article says that Disney and disability, media representation of disability in Disney and Pixar animated film, and it says that most of the films which is made by Disney, the portrayal of disability is not the way it should be. So rationale of this study is to find a way through which we can reach to the larger population, larger audience, and that is why these films were developed. Now the objective of the study is to see the effectiveness of the animated film, those 5 films which we develop about the how they are able to create the awareness among general public, and also to compare the effect with respect to age and gender. So hypothesis says that null hypothesis was adopted, and it says that there will be no significant difference in the awareness of the disability through animated film, and also with respect to gender and age variables. Methodology: single group pre-test poster design was used for the study, and the sample frame was selected from Mumbai and Navi Mumbai population, those who are visiting to NIPID Regional Center Navi Mumbai, and also those who are attending the community based programs which we are conducting in Mumbai and Navi Mumbai area. So we showed all the films, and we used a questionnaire of 10 questions for each film, which is multiple choice, and then sample size was 165, out of which 123 females and 42 males between the age group 10 to 60 years. Research tool, as I said, developed 50 items questionnaire, 10 items per story. And then the findings says that t-test was used for objective number 1, and it says that significance difference was found among the population. It says that animated film were quite effective, but when we come to the gender and age variables, we had not find any significant difference, which implicates that it is equally effective for both male and female, as well as different age group which we had selected, 10 to 20 years, 20 to 30, 30 to 40, and on. So the major discussion is that animated films were found to be effective for creating awareness about disability rehabilitation, and no gap was found between the gender and age group. So generally we assume that children are more into animation and adults are not liking the animation, but my study says that now adult population also liked and they responded well. So limitations of the study is that population of Mumbai, Navi Mumbai, and the age group is 10 to 60 years. Below 10 years we had not taken into consideration, because the concept which we are there in the stories, we found that 10 plus age group will be better. Uh, and then Hindi language is one major area. So these films are bilingual, actually I would say Hindi as well as sign language, Indian sign language. So that was the limitation, because other language we had not considered, and it is not yet developed. So recommendation for the further research is that the project may be undertaken to develop animated film in languages, other regional languages. We had got requests from SSA Telangana to translate the whole material in Telugu also, and same way we are getting feedback from other places also. And then we need to look in more themes which is related to more burning issues of disability rehabilitation. So in future, if we get permission for the next phase of the project, we'll try to look into that. And similar studies may be conducted in other parts of the country. So conclusion is that the study throws light on need and significance of creating awareness in general public through animated film, which is in line with the earlier research work also. One of the research which was by Kalma et al., which says that uh, if appropriately online animated videos are shown, it could be a powerful support for creating disability awareness. The finding of the studies are matching with previous attempts of promotion of girls' education in India. Earlier, Meena stories were developed by UNICEF in the country, which were to create awareness and sensitization for promoting girls' education. In the similar line, our animated film also found to be effective in creating sensitization and awareness about disability rehabilitation. These are few suggested readings, and all the animated videos were released by Honorable Union Minister Dr. Virendra Kumar ji on 16th February of 2023 during Divyakala Mela at Mumbai. So with this, thank you very much. I think I matched with the time.
My personal request.
Yeah, ma'am.
I don't know the audience also. Can you show us glimpse of your film? Is it possible?
Yes, ma'am. It is possible. Only thing it was shown in the beginning, so I can show it now. Shall I show
Just
it?
a shot. I don't know. You all agree? No, just
Yeah.
a glimpse of it to see how his parameters are matched. To understand the
Rahul
research
ji,
implications.
I request Mr. Rahul to please show. Actually, every video, the timeline is 10 minutes
No, we don't
across.
want the whole thing.
Yeah,
Just a
glimpse. Yeah.
I have a concern while set up wheelchair. You have mentioned two things. NIPID, developed this animation. You have kept it in in a section of limitation. So what was the reason? NIPID is developing this, so it is asset, I think. And the second is very important that you have taken the sample age ranges 10 years to 60 years. So that is very, huge range. So definitely 15. Okay, after that we will discuss.
Actually, ma'am, the population which I covered includes siblings and the parents and general public as well as the student, those who are college going students. So we try to cover with all age ranges, whether it is effective or not, or is it only effective to a particular age group. That's why we kept that wider age range for our sample. And I said it is NIPID because nowadays other agencies are also coming up, and they are developing the animated videos.
सर
And
मैं अंदर आ सकता हूँ
than that other online resources. So my study is limited to the NIPID videos only, not beyond that. So I mean to say that, although it's a asset for us. So this is the story number 5, which is about the vocational rehabilitation and employability, in which there is a story. Sorry, this is for inclusive education, in which there is a parent who is taking the child to the general education, and principal denied admission. But when it was supported by a special educator, and when special educator meets principal and tell him about the legal rights and provisions for the education of persons with disabilities, the mindset of principal changed, and now he is ready to accept the child and give admission. So this was the theme of the whole story. If ma'am you permit, I can run this.
हमारी बेटी टीटू है, हम इसका एडमिशन आपके विद्यालय में करवाना चाहते हैं।
आप किस कक्षा में अपनी बच्ची को एडमिशन दिलाना चाहते हैं?
कक्षा पहली में सर।
लेकिन देखने में तो यार बड़ी दिखती है, क्या पहले कभी यह किसी विद्यालय में नहीं गई?
नहीं सर, हमारी टीटू दिव्यांग है, इसके कारण अभी तक हमने उसे किसी विद्यालय में नहीं भेजा। लेकिन हमारे पड़ोस में एक शिक्षक रहते हैं जिन्होंने कहा कि टीटू को जल्द से जल्द विद्यालय भेजिए, इससे उसे बहुत लाभ होगा। इसलिए हम इसका एडमिशन कराने के लिए आपके पास लेकर आए हैं।
लेकिन हम अपने विद्यालय में विकलांग बच्चों को एडमिशन नहीं देते हैं, इससे दूसरे बच्चों को भी समस्या हो सकती है।
So this is a general problem which generally parents face when they go for the admission. School directly or indirectly deny to the admission. So this is the way, and in this story I also try to highlight the role of special educator. How important is that, and where parents can contact when somebody is denying the admission for their child.
I would like to give you the feedback. I like the way the expressions have been beautifully coordinated in response to the answers given by the principal or whatever he's, informing them, including the child. That simultaneous, how in a context how a group can behave, it makes a lot of meaning for it. So animations become effective only when those finer details are highlighted or at least made noticeable. So that probably that's why the impact is good.
Yeah. And for that, the expert committee of NIPID I am thankful that I got a lot of suggestions and advice time to time to make the final video, a lot of corrections and suggestions were there which were incorporated. So
Are you planning to get it translated or something? Is there any plan?
yes, ma'am, we are trying to put a proposal, and once it gets approved, we try to translate in major regional languages so that a larger audience should have access, and the background and the kind of things which we try to keep is simple language, not the technical word, and people their look and other thing people can connect, particularly rural areas. People can connect, so we had not given a very uh, urban or higher income group kind of look and attitude. So majority of people can connect with the characters that we try to do.
Any question from the audience, or suggestion, or any experience?
Any experience?
Ma'am, topics that I covered are causes of disability, that number one story, which all the stories are available on our YouTube channel. So this is story number one, which is about the causes of disability. Then we talked about the prevention of disability, the second topic. Then the third topic was early identification and intervention of the child. What to do, because parents are not aware of the milestones, and even if they found some developmental delay, they have a wait and watch practice. So they should immediately go to the early intervention center. So it was focused on that. The fourth was on inclusive education, and the last one was skill training and vocational education. So all these topics we try to cover with the latest schemes and benefits of the Government of India. Ma'am, depending upon the need, I am planning to do it on sports training, Special Olympic. I'm trying to make a video on 2E concept, that is double exceptional children. Our children are having exceptional ability. So being a child with disability is one exceptionality. Being a child with special talent is another exceptionality, and now that is covered under NEP. So and also on NEP itself, different provisions which is there in different areas. So definitely we have thoughts now. All depends upon the approval by the academic committee and other competent authority.
You don't want to do it on UDL?
Definitely,
your passion.
Yeah, that is my passion, and it was credit goes to you, because I did my MA dissertation on UDL under the guidance of Shelja Rao ma'am in the batch of 2011-12 from the same institute. So definitely that is, and then I did my PhD on UDL itself. So, but I am trying more areas, explore more areas. Definitely UDL is very close to my heart, and I'll try to do that.
In 2011, when he was finalizing his dissertation topic, in fact, I asked him to give an orientation on UDL to me. So that was the time when we did not know much about it, but the youngsters, because of their familiarity with the internet and all that, they were looking for new topics. So that's how I got introduced to UDL. So I acknowledge that in public. I got introduced only through his topic and dissertation. So I had to do my reading also, no, to guide him. So that's how we worked as a team. This is what I wanted to share with all of you.
Thank you, ma'am. Thank you.
Thank you so much, Dr. Ravi Prakash. That was very crisp presentation. Because of shortage of time, I would request all the presenters to be, we would be having a 10 minutes time, and the first beep will be at 7 minutes, and then you have another 3 minutes to complete the presentation. Our next speaker is Ms. Mridula Sakle. Her topic is Supported Work Center, a successful model of employment for PWIDD. We welcome you, ma'am.
I would like to welcome Mridula Sakle ma'am, and she is one of the expert in the field of disability rehabilitation. Presently, she is associated with Muskan, and as all we are very much aware that Muskan is doing wonderful work in the field of especially skill development and rehabilitation of PWID. So, ma'am is a very known person, and I hope that her topic, which is related to work center, a successful model of employment for PWIDD, which is one of the challenging for all the PWD. So, ma'am will focus on, what are the challenges and what are the best model. So, as we always talk about, we have to take a lead to create the model. So, I hope all of you will enjoy. So, now, ma'am, would you like to share something about? I'm looking forward for the presentation because I know we'll have a great learning with that. Thank you so much, ma'am.
We would take all the questions at the end of all the presentations.
Good afternoon, everyone. As Amritaji said, and I'm really looking forward to presenting you a model of supported work center because this is a model we started in 1995 when we had nothing to fall back on. And this was our experimentation, and I would say that it has really become quite successful. So, as I'm saying, that there is always a question with parents that what would our child do once he passes out of school? They are taken into school in certain schools under the name of inclusion, but then they go in for vocational training. Then once they finish the vocational training, then what? There was no society there who was ready to accept them with their vocational training and create jobs for them. So that is where we came in and we tried to create jobs for them. What See, adults with intellectual and developmental disabilities might be compromised in their intellectual and cognitive functions, but their psychosocial needs are like any other person. They are also wanting to do something in their lives. And adulthood being the longest span of one's life, everybody is wanting to do something creative, something productive during that time. And we feel at Muskan that human mind is programmed for learning. It's for us to tell them in a way they understand and they can do it. So, in successful employment models, what we have seen is what we can say is that mainstream employment is one of the employments where only 15 to 20% are employed. Supported work center where they are given a little support and they are being productive goes to 60 to 70%. We call another model as activity center where we have high support need people maybe with multiple disabilities also, and there is supported self-employment which takes up around 2 to 3%. Here I say supported work is self-employment because we are experimenting with it, and again we are also experimenting with the model of work from home. We have four models where we work: mainstream employment, supported work center, art and activity center, and supported self-employment. What are the occupations they can do? They can only do the occupations which are simple and well defined, which involves assembly line. About assembly line, I would be speaking a little later. Any work which is hands-on and repetitive, that would mean which is not abstract but concrete, and which brings about visible results for them, because that is what motivates them. And here when I am saying repetitive work, again I would say they have a fantastic capacity for freedom from boredom. We get bored, they do not. And now why supported work center? Because 60 to 70%, as we have seen, people with intellectual and developmental disabilities can work in supported work center. Why? Because this gives them a meaningful engagement, helps them being productive in non-competitive environment. They receive right support. They can be given challenges and their understanding can improve, to bring their self-worth, confidence, motivation, and a more fulfilling life, enhance their life skills, make them a part of workforce. Each person's skill and strengths are used in assembly line, so everybody is working. Again, it also encourages the lives of the people with families of the people with ID, and it also creates awareness in the society by saying that it changes the perspective in the society by creating awareness. As I said, I will be speaking about assembly line later. This is what the assembly line is. That it means that a job, we always break down the steps and we do the job analysis, and each step is being given to a student or a trainee as we call them. So what happens in the assembly line is that they focus on the worker's strength, which enhances their motivation. Workers of different skill sets can work on one product. Group activity, uh, it's a group activity happening, so there is a healthy interaction and bonding between the workers. Again, we inculcate quality consciousness in them, so quality is being checked at the each step. Targets are set, so the targets are met by them. More variety of products can be introduced because we have a long assembly line, and training can be provided in the assembly line for them to train in something next and go a step further. What is the teacher's role here? Definitely there would be a teacher's role because this is a supported work center. Teacher's role would be understanding the strength of students. Never look at the weaknesses, please only look at the strengths. Forming the assembly line where they are able to use the skills of all the students. They all have well-defined roles in the assembly line. Making work structure challenging so that it challenges the students who are working there and so that it motivates them to move further. Defining their goals to them, with them, sharing targets and work structure every day. What are the keys of successful work center? Would be selection of products because they should be, as I said, easy to make, which would be hands-on work, repetitive work. Another would be consumables because if you keep making products and you are not able to sell them, then what are they working for? Research and development of the product, which is a continuous process. Task analysis of how the products are to be made. Skill identification and transfer of skills to the workers. Standard operating procedures, forming assembly lines, setting up the targets, methods of quality control for teacher and for students both. Continuous upgradation of skills and capacities, flexibility in work structure according to accommodate the market demands. And here the most important would be to focus on the human profit rather than the economic profit right now, I would say. But yes, we are always moving forward in this area. Why structures and adaptations for them? As you would see in the picture, that there are adaptations. There are adaptations which we have shown. This is for making them more productive. By giving them adaptations, we make them more productive. What are the important aspects of supported work center is having a well-defined target so that the work structure can be maintained, quality consciousness, procurement of raw material and quality of raw material, storage, well-defined spaces, well-defined work ethics, each student having their allotted area of work, and very good communication between the teachers and the students. And now what is the, because see, when we are talking about the supported work center, a big question mark comes on all the NGOs' minds is that bana to lenge bechenge kahan? Which has been, yes, we have been successful in a way to break that to a certain extent. It is about seek parent support first. They are your first ambassadors to take your products to the market. Volunteers, ask volunteers to go and do the sales outside in the venues to create awareness. First step would be creating awareness, next step would be the product would be sold immediately. Never go on something which is charity selling. That is how I earlier only I said that the quality has to be maintained. Don't go in for charity selling. You are going to sell it for 2 times, 3 times, not the 5th time. So it always has to be quality and what the market demands.
promote the USP, let the students work. That is what is our USP. That people with disabilities are working. That is our USP, and that is what we stick to. Then having a very, very good public relations, and here I would say to seek help of your PWDID. They are very good ambassadors. What we are doing, we are teaching 20 vocations. I have given the names. We have employed around 500 people since 1995. We have 120 products being made at Supported Work Center. Average retail customers for us are around 10,000 a year. We have 50 bulk buyers today, but there have been many who have moved away, and there are many who are going to come forward. Our annual turnover is 35 lakhs plus, and we develop 2 new products every year. What are the challenges? Because challenges are the main challenges that people don't see supported work center as they would see a mainstream employment. This is the where we need the attitudinal shift. Marketing of products made by SWC, yes, I have put it here as a challenge because yes, it is a challenge to some. To maintain a fine balance between cause marketing and commercial marketing. There is a very fine balance. We are working for a cause. We should not shift from working for the cause. Bringing people out of the charity mode. No government support. We have never had government support since Muskan's inception. Balancing between production and marketing. It is always a very fine balance between how much you make and how much you sell. So you always have to keep that fine balance. Regular workforce remuneration for the workers at SWC. Thank you so much. So if there are questions, yes, as she said, later I will take the questions. Thank you.
Thank you so much, ma'am, for throwing light on supported. Throwing light on supported work centers, that definitely it is going to be an answer for many of the parents who are looking for some solutions. Our next presenter is Mr. Shrimon. He will be presenting on behavioral intervention to treat speech sound disorders in children with autism.
And thank you. Good afternoon, everyone. I'm Srimon. I'm a BCABA, and I'm going to present the research paper conducted by Dr. Smita Avasti and Sridhar Arumudan. And yeah, so the paper is about improving articulation in children with autism. So we all know that articulation issue or working on articulation is having a significant or importance in working with the kids with autism, because it was shown that every 3 kids diagnosed with autism, one among them having speech clarity issues. So when we are working with them, making them say the word or the words that they are having articulation issue over and over again, it is going to make them frustrated, and then having failures, that they're going to get frustrated. So the training may not go good, and most of the time the kids, their words are being misunderstood because of the articulation issues. And whenever they say stop, they may say stop, and if it is like in a word like cheats, or they may say tippu and all. I mean, it usually we misunderstand them. There are some literature available that works on articulation issues like shaping, chaining, and etc. And one among them is the vocalization imitation training with sufficient response exemplars. Now, I just want to explain a little bit about blends. So blends are when we join two consonants and then they try to speak. That's called blends. For example, in like words like black, mist, and all. So
excuse me, Shimon. We all know what is blends. Please move on with the topic.
Yeah, sure. Okay, so sometimes what happens is like they omit the sounds when they have to blend. So there are researches available, exit and NISIT research about blending it, blending the vocals. So our research is an adaptation of or replication of this research done by exit and NISIT. And this current study, what we do is teaching the children by specifically working on 3 blends and only working on the first word of the blend and then later probing the other words selected and observing whether the articulation is achieved without any specific training. So there were 2 participants that we have selected. Both of them were diagnosed with ASD and having speech delays. And it was done in our ABA sessions and our centers. And so these are the blends that we have selected to them. For TA, the child 1, that we have selected ST, SP, and SM blends. So for each blend, we have selected 10 words each. For example, yeah, you can see that. For in ST blends, we have selected 10 words, and SP the same way. And for other child also, we have selected the same way. But we ensure that these words are selected, which are having a significant or social significance, or it can be useful for the communication. And so we the dependent variable was the correct articulation, and the independent variable was the training using chaining and shaping and other procedures. So in the baseline, what we did is like we assess the 3 blends that we are targeted by asking or expecting the child to echo it when the assessor is modeled, and noted down whether it's correctly pronounced, and each some tokens were delivered after correct response, and after 12 tokens we were allowing the child to have access the reinforcers. So I can just play some audio. I'm not getting it, so maybe if I have time I can later I can play it. And so the treatment was in a session 3 to 5 times we have done, and in 5 days a week we have done that. And the intervention was, as I explained before, we selected the selected words were interspersed with other words that the child can say, so that he's not getting frustrated. And you use the shaping procedure and chaining and reinforced that those behaviors to come up. And once we are finding that the child is able to make the blend, and we were reinforcing and strengthening that behavior. And then we were tested all the other words. Initially we have trained 1 word, and then once we identified that he was able to say, then we tested all the other words which are not trained. And then if the child was able to make correct responses for other 9 words, we were going to the other blend. So the intervention continued and till all 3 blends were achieved. And after that we have maintained it in between the sessions. And so you can see the results. I can show you. Here the blend we have selected was stop, and after training for 20 days, after learning, we made a prop, and then it was identified that the participant was able to say all the other 10 blends without specific training. The same as the word spin. It took a little more days, like 20 days, more than 20 days. So the second participant, that she required a little more training, and we have done more number of words trained under that, and then she had to go to the other words which are untrained. So we identified that through the research that vocalization training with sufficient response exemplar training was making significant progress in them, and the prompts that we are used, lip, tongue, teeth position prompts, were effective. We identified that, and I think we identified that the plan that we have implemented were effective with profound speech, the sound disorders, and the number of sessions and the number of words directly trained could be higher. So we worked only on the initial blends, but we could have done we could have worked upon the end and middle positions of the blends, so that we didn't work on. So that was a limitation of the study. So thank you. Just one.
Thank you so much, Mr. Shrimon. That was wonderful. Our next presenter is Mr. Praveen Varghese Thomas. His topic is exploring the scope and efficacy of artificial intelligence-based approaches for children with autism, cerebral palsy, intellectual disability, and Down syndrome. We welcome you, sir.
We would like to welcome Mr. Praveen, and as his topic is very, important for everyone, exploring the scope and efficacy of AI-based approaches for children with autism, cerebral palsy, intellectual disability, and Down syndrome. I hope presenter will help us to understand all these mechanisms, and but before with that formal presentation, I would like to say you have only 10 minutes. 7 minutes for your presentation and 3 minutes for question and answer. Thank you.
Thank you so much for the reminder, ma'am. Thank you. Artificial intelligence seems to be a little inhuman when we discuss about it. I personally feel it when I go to my company, which is called as Tutorials Point. We basically work with algorithm, and we are particularly into defining artificial intelligence. And my core is social work. So when I go wearing a kurta in an MNC, people look at me, how human this person is. And I look at them, how inhuman they are. I mean, they might be working in a cabin, they have definite timelines. So I look at them in a pity way, and they look at me, how liberal you are. I work as a learning and development consultant there, and I have a background of, I did my PhD in social work, and I'm fortunate enough to be with people who are in MNC suffering a lot, especially mentioning suffering a lot in terms of emotions, in terms of being with family and all. And to this particular topic, this is a personal endeavor. This is a personal interest where my wife is also studying here. I could personally relate certain things when I have a 1-year-old child. Every day when we are both into psychology, we always tend to look at our child in a very different perspective. Is her, aggression is somewhere related to ADHD or something. So we have this thing in our mind because we have studied psychology. So I could relate it with my co-workers who are there in the MNC, and I can also correlate it with the people with whom I have researched. Back in 2015 onwards, I was there in Punjab for working with the slum youth, where I have seen a lot of people doesn't even know what their children are behaving for, what they're aspiring for, what they're asking for. Are they able to talk? They don't mind. They just need food. So we are privileged enough to talk about AI, but there is another section of people who doesn't even know about what their children are up to. If they are not talking, you are dumb, you are not able to earn, you are sidelined. So there are different sections of people who might get affected with AI. We see it as inhuman. I'll give you one small gist of before this, because I need to set this context so that you can understand it better. Me and myself, my wife got quarreled for something and I was upset. Suddenly I get a message from Swiggy. Do you want to elevate your mood having some brownie? They are artificially understanding what kind of food I like. Even before my wife asking me, Zomato or Swiggy has an intelligence to understand what I like. Can't we do the same with the children whom we are referring to? This conference is referring to. So I kept it as 85% uploading. AI is getting uploaded to our life, our system, up to an extent of 85. If you are worried at how much 85, it is a big number, then let me remind you, you are not updated. We are surrounded with AI, but we are not realizing it. Each and every actions of yours, your sense, your likeness, your fondness, what you have spoke to your spouse, everything is being captured here in AI. Now I get into the perspective, now I get into the paper. I also have a submission, humble submission here, because this is a conceptual paper where this is going to be a start for me. I'm going to go for a book, entire book on AI, and also a company is going to look into the AI possibilities, because Hyderabad is going to be the health capital of India. If you are not aware, 3,800 rupees are going to be into the pharmacy, not only for medication but also for the AI interventions, where NIPED can also pitch in. So I see myself as a bridge here between NIPED and the technology. So let me quickly move through, and I'm not going to give you introductions because already I've done. I've taken some time. So what I'm going to do is, what is our role here? Through the literature and through the understanding of what we have run, we have actually triangulated our research literature review, basically by two authors being there, and there is one more author who is not the author, but then to just triangulate whether we've been capturing the correct thing. So let me put it this way. Our research question was, what is the effectiveness of AI-driven therapies for improving? How can it be improved? And what I said in the introduction, how can be useful for us? The eligibility criteria was 2015 to 2021 literature, the literature which been available between 2015 to 2021, and the focus completely on the evidence-based research with, as you are aware, PRISMA criteria. And study selection was the face validity with the researchers, because this is a conceptual paper. But then don't demean the conceptual paper, because that is the start of the next trend. Data extraction was particularly through, as I said, the evidence-based researchers being captured and extracted. Within this slide, I'm capturing everything that I've did so far. So what we have done is, we have compartmentalized into three, and we have studied a couple of, we have actually reviewed a couple of articles, to be very precise, 12 from 259. 259 articles or researchers you can see if you particularly look into this topic, but we have captured only 12 because of the criteria which I have mentioned. So ASD, there are a couple of researchers which tells that it improves. You have to special focus on this. Every research says that AI improves. AI improves the social ability. AI improves the motor ability. But none of the research has said how. That's very demeaning, and that's very unwelcoming, unmotivating, that these researchers, including us, are not able to articulate in a way that why and how it is working. That was precisely my question during the previous session as well, that we also have to understand the qualitative, quantitative importance of paper, and that is exactly what we captured here. I request everyone to go through the paper which is going to be there in the proceedings. So this is the essence is nothing but every AI-driven app, website, or whatever things we have been capturing or developing, including the animation. I have one note for the animation as well in the paper. It says that it improves, nothing more than that. But for a practitioner and for a parent like me, I need to understand how it is going to be. Let me quickly show you one video where we see it as an inhuman thing, but parents are experiencing it as a much wider, much helpful aid or a tool. This is one among those. where her child is looking at her for the first time, eye to eye.
The minute he put the glasses
Just
on,
40 seconds.
he just lit up. He made connections with the entire team. And how did that make you feel?
This is a celebrated AI product across the world. It is not at being
Technology is bringing you
and this company is called as Empowered Brain. Another one is called as Autismo, which is nothing but a game based, as we have currently pointed out, like animated things, and games can actually move, elevate the motor sense and also the cognitive abilities of children with NDDs. Autismo is one app which you can also access as a practitioner, can access and understand how this is going to help your children or the people who are with you or asking for the help. There is another one called as Wobot. I'm not going to give you the exhaustive list, but just making you familiar that these are the things. Mitre is another app which actually captures the movement of your eye. How you move your eyes, how wider your pupils are. So it actually captures the babies or the children or the adults' ability to look at people, how passionately they are looking at, how affectionately they are talking to. All these things can be captured through Mitre. There is a question of accessibility and price. I'll come to that. I'm rushing through. And there is another app which is basically you can use the virtual reality possibility. You're thinking about money part. I'll come to that later. With virtual reality, they are helping ADHD children, children with ASD, children with CP. There is another one called as MIT, which is Mental Imaginary Therapy for Autism. There are plenty. Now, the major thing is, what is the role of the mental health practitioners, and also how far this is accessible? Now, we've been a little reluctant about laptops getting integrated to our life. We've been reluctant to get computers placed and learn computer. There were strikes going on back in Kerala. I'm from Kerala, from the trade union saying that computers are no more allowed in our company because it can replace humans. No, that's not the fact. I am here to propose only one thing through my paper. Is nothing but psychologist, rehabilitation psychologist, or say the entire mental health professionals has to stretch yourself from the traditional way of thinking and get more into the technology part. Bring your micro experiences, give it to us. You can get the pattern in 1 second. That's the technology which is going to be there. I will take 1 more minute. Sorry for that. I need to finish it, and I don't believe that I don't get another opportunity to put it forward. I'll just take 1 more minute with your permission. As Shailaja ma'am is passionate about what she is, I could see the vocal emotion which she is carrying. I carry the same, so I have the ability, right to talk about. So I'm talking it out. Just 1 more minute. I just want to tell you that as a researcher, if you're going to the clinic, if you're being with the students, if you're being with the patient, if you're being with the caregiver, you get your qualitative information other than testing. Where are you recording your qualitative informations? Students, I'm asking you, where are you recording your qualitative inferences? That's there, and next day new people comes in, there is new set of sets coming up, the test coming up. So here I am proposing to the paper, and also from the technology background I have, if you can code it down with a particular app which is in my mind, that is exactly the proposition, where you can qualitatively add all your elements, all your feedback, your emotional biases, everything, and AI can bring in trends and patterns which can help you for the macro level policy changes. Towards the end, I just want to put it this way. Our cartoons are of black people, black characters are there, sensitizing the color discrimination, to stop the color discrimination. Why can't we have the normal regular cartoons like Chota Bheem? This is just came in my mind, just putting in Chota Bheem and other things, having characters of disability, having disability in the character which has disability, a character with ASD, a character with CP, and that is how we are going to make people aware. I was not aware about the cartoon until this was played here. How are you going to make other people aware? We need to dilute ourselves and make people understand what I'm making. We don't have to pretend ourselves as experts coming in and giving solutions. Let's learn together. Let's celebrate the dualism: patient, children, and the practitioner. That's what I do, and I also promise you to go through. I urge you to go through the paper, and let's work together And let's not stop it here. Thank you so much.
Okay, we have finished with the presentations in this panel session. So if participants is having any queries, you can have quick questions because we are running out of time. I hope no questions from participants.
Post lunch, it is very difficult to sustain, to catch your attention, but I'm sure that all the presenter has presented so well, and they they have done justice with us. And personally, I believe that it's a very different forum, that one person is talking about AI, one person is talking about the skill development and employability, whatever we have. And Ravi has shared animation, so, and therapeutic side, Simon has shared how we can, provide the service, provide the services, speech therapy to the person with autism. So these are the, sharing we are sharing here, that how technology and other thing can help their, management of disability in an easier way. Definitely, we have to work together, and we have to, think about ourselves. We have to do lot of exercise, particularly from ourselves. That if we are, seeing the patient in our clinical setup, definitely they are teaching lot of thing to us. And qualitative and quantitative both are very important. Of course, as you said that qualitative analysis is very important. If we do Rorschach, if we do VSMS, of course one VSMS is not similar to the other same diagnostic case. So that is very important, that here we can start and we can use the technology, and we are using. Definitely we need to learn many more things. So thank you, all the speaker. Over to you, ma'am.
The best way I can conclude is, Praveen, you please coordinate and combine all the speakers' products and make a meaningful outcome out of it. That will be the best experiment we can do, because you're running from virtual to realistic, concrete experiences, and then you're putting it into artificial intelligence. So I think that's what you speakers should all do together after this. Very good presentations. Each one had a different perspective. I'm sure we all have expanded our viewpoints, knowing the potential possibilities that the speakers have presented. Now it is for us how what permutation combinations we can use, under what context, and for what skill we are targeting, or what is the outcome that we want to achieve. So this has been a very good session. My comments on, can I just take a second to comment on it? UDL, I think, still needs to be incorporated, which can possibly come in. I think you both can work together on that with the animated effect. But one thing about the animations, which I always, which you have taken care already, but I would like to share to sensitize the audience. When we're talking of animations, let us not take fancy stuff. If it is as close as to normal, what the child is familiar, the child will definitely participate and benefit out of it. And of course, these are made for parents as well, guardians as well. But when the child is watching it, it will definitely have a deeper impact. This is one caution word that I want to give. So I'm glad that you have taken. There were times we used to do same films, but with parents themselves, model parents, and then we shoot the videos. And this is what we used to use for awareness. I'm glad this medium has been introduced, more ethical and more neutral. All right. And madam, your presentation was excellent. I think a lot of good work has gone in, and since 1995 you've been doing. You've almost grown with PWD Act. So I'm sure you have solutions for it with the upgrading. So, right. So whatever, madam, my request to you is, it's a wonderful model. You've taken care of every detail. Is it possible for us to see how things have to be applied differently, at least under the sub-classification of ID categories? If you can think of that. So as a community working in this field of ID, I'm not talking of intellectual disability alone, but I'm talking about a sub-classification category, which includes 4 disabilities. If you can think how your learning can be transferred to these 4 categories.
So if you can probably escalate that, that would be a great service to the community. And Shimon, yours, I was actually wanting to see some samples possible. Yours is an extreme, I think it's an experimental study. So it would be nice if you can share, not now, but maybe whenever you present again, or if you are trying to give some more feedback on it, maybe some sample. Okay. And Praveen, you need to coordinate. That's a short message that I have for you. Because artificial intelligence is a broad platform. It can be applied, it can be inclusive, and that's what we need to take back as a learning from here. Thank you so much to all of you, and if any questions, you can ask.
I have a quick question. Can I take some time? Yeah, so I am an app developer, particularly working for children with neurological visual impairments. So, my request to the whole team and everyone present here is we often struggle with the biases around the technology, and it often becomes difficult for us to enter into the market and convince the therapists and also parents to use it. So I don't say that the applications completely replace the conventional therapies, but the integration can go a way like a way forward, and also can have a better things in terms of the affordability and making the things easier for the therapist to work on. And another thing I have for Praveen is I can see that like when you say AI can make the things lot of things easier, but so one thing we struggle when trying to keep it forward in terms of the into the market or even proposing it to the governments is the quality. I think someone already discussed regarding it. How do we show that the child is improving while using this product, which we don't have a very standardization of the assessments coming in from the conventional therapy itself. Like each child has their own time to takes their own time to improve. So how do we quantify the whole thing? So it's for the even the experts if they have any.
There are two things. One is about what you have said, the quality of the applications. As I said, like we are losing a lot of information. What is going to happen after this conference? You're getting a proceeding. That's it. What about the qualitative aspects of what we have discussed right now? Ma'am has told me to coordinate, or perhaps having a discussion. What is going to happen with that? So we need to capture all those elements. Everything is information. Your question is an information. Who is going to capture it? There we can use technology. Now that the data has been captured, that makes your app more qualified enough to present it over a government sector, where you have a lot of information. Your app or whatever you're designing is going to be the par excellence quality kind of, because it has a lot of information. But unfortunately, we are losing a lot of energy and a lot of information. Right? I always used to ask the students here when I have a chance to encounter them, where is this qualitative, as I said earlier, where is this qualitative information going in? That is more important for your app creation. We cannot just simply go for the macro level numbers. We have to go through the qualitative, and that makes the artificial intelligence more intelligent. That doesn't make the thing that people who are here, like me, mental health practitioners, they're not going to get wiped out. Artificial intelligence can only work dynamically, productively, if you feed it properly. And to feed it, the qualitative essence is needed. So my first proposition is get the data. Don't believe or don't think that the numbers are the data. No. I personally don't feel, and I'm coming from the technology background, qualitative essence is the data. Somehow we are, not understanding that. We have to understand that. Second thing, we've been talking about the accessibility. We have more than thousands of Anganwadis, that's what we call in Kerala, that is the child development centers. If you remember, you and me, or maybe the people here, have watched Shaktiman in one house when the TV was there first introduced. But now we all have TVs. Can't we do the same with artificial intelligence? We have community centers in all the villages. We have CPO, child protective officers, and the centers there. Can't we do that? Can't NIPID, as ma'am was correctly saying, can't we do it in Telangana with the help of the ministry and also with NIPID being here? That's the data. We are wantonly forgetting what we have. and we are aspiring for something which is not there. I hope I answered your question.
Thank you. Yeah, definitely.
We can probably address the second part of your question, which is that here I am, I've understood the requirement and I've developed an app. Has it made a difference to the child? Has he made progress? I think that was also one of your questions, right? Yes. So basically, I can say there is a array and battery of assessments available, tools available, but you need experts. But we can definitely help if you collaborate in terms of, let's say, his social skills have improved, his verbal communication has improved, his language vocabulary has improved. We will be able to. The important thing is to measure, quantify, and finally say that yes, because I introduced this intervention, we managed to show this improvement. It's possible with definitely single subject experimental design. So anytime we can be in touch, be happy to collaborate. Yeah, thank you.
Thank you, sir, for giving a very good suggestion. I just have one thing to add in continuation with what has been suggested now. Whenever you talk of advertisement, you already have a goal which you want to achieve. So you need to analyze your goal first. For whom are you doing it? What do you want to bring about a change in? That itself becomes your reference point. And how will you build up the measurable, indicators to say whether it's helped or it has not helped? So you need to go with an open mind if you're going to experiment it. You not say, yes, what I'm doing will help. Yes, it may not help also. And how is it deviating from what you want to achieve? So when you're an advertiser, you're already taking the data in detail because that's what you want to fill the gaps. So if you don't understand the gaps, if you don't understand the purpose, then you can't be an advertiser. Right? So first you are advertising, the training that you have taken as an advertiser itself is an asset to you. If you really want to have it. The only thing is you have to be methodical. So that's what Praveen was saying. Don't miss the data. Whatever comes, you have to organize it, then link it with what changes you want to bring about. You think it has any rational connectivity, and then with the small sample, you will test it out, see for the outcomes, then you move on. You keep building the design towards desirable levels. So I think it's nothing happens at one attempt. One has to keep on improving it, fine-tuning it. So a lot of patience and faith in yourself. Thank you.
Hi everyone. My general question. I'm working as a special educator in inclusive school. So I'm looking for one document. Whenever new parent comes, I want one document like what are the assessments they need to do, and what are the rights, and what are the apps available for them for any kind, autism or Down syndrome. Is there any document or anything available in the internet? So that I can give it to the parents, and these are the things you need to do.
Related to course curriculum or
no, related to the kid
child.
For the child.
So you can refer our institute website. So there are so many materials.
Yeah, I agree because as a special educator I have gone through. But is there any simple thing they can see? These are my rights. These are the assessments they have to go through, and these are their rights, and these are the apps available. So can you use it? So it's a bits and pieces. I'll get it, and I'm helping them. But maybe I will also miss something.
But for whom do you want this?
For my students. For parents, I want to share it with parents.
I want a clarification from you. You want to have it to aid your ability to place the child correctly or identify, facilitate.
Because myself,
to use it as a sensitization material.
Yeah, myself, I'm attending the sessions whenever I get time. I'm getting it. But parents, I'll give information that they will miss. If there is any single document or an FAQs or anything,
for 21 categories, you may not get in one place. You may have to
at least, yeah, the category wise.
For the 4 conditions under subclassification of ID, you can get it. We have manuals, we have handbooks published, not by one organization, many of them. And even if you can contact the National Institute's librarians, they will also help you. But there are also brochures which are available. You look at the brochures which are displayed on the website. of all the national institutes for different disabilities. And if that you can download and use it for your own suitability, that will help you.
Okay, ma'am. Thank you. Thank you so much. I now request Shailaja Rao ma'am to felicitate the presenters.
So please, thank you.
Presenters, please join together for a group photo. Srimo, please join for photo.
You're a youngster, you have more energy.
Sorry. You want to join me?
Thank you.
So quickly we are moving to the next session. I request Shailaja ma'am and Amrita madam to stay back on stage. Amrita madam, please be on stage itself. So I request Dr. Sunita Devi to moderate this session. And so this is the last technical session we have. So we have 3 presenters. I'll call others. So I request the other presenters in this technical session to come on over to stage. Mr. Shankar Madam and Sri Rajendra. Sit.
I am Atul Srivastava. Atul Srivastava. Atul Srivastava. Yes, yes. Atul Srivastava. Department of State
So we'll start with the session. First presentation will be on the topic disability awareness and community participation. So the presenter is Mr. Shankar Madam. He is a well-known rehab professional in the state of Telangana, and he is having a rehabilitation foundation, Sahara Rehabilitation Foundation, which also runs a college of special education. So I request Mr. Shankar Madam to start with the presentation.
Yeah. I have it now again. I think I have watched it.
Good afternoon once again. This is the last session, so I hope all of you will enjoy. I would like to take the opportunity to welcome Mr. Shankar, who is in Sahara Rehabilitation Foundation, and he is going to, address a very important aspect. Personally, it is in my heart: disability awareness and community participation. So all we know that without community, involvement and community participant, our all program will be failed. So, sir, we would like to welcome you, and but we have to stick on time. You have a 10 minutes, 7 minutes for your presentation, and 3 minutes for your question and answer. Thank you.
Good afternoon to everybody. It is very difficult for a speaker to get the attention when the subject is about community medicine, which is relatively boring. We all might have had community medicine. It is a residual subject in our studies, I guess. So after such a wonderful, interesting scientific subjects, rational subjects, community medicine is going to be quite tough. But let me rush through in the next 10 minutes what I could do the best. So I'm Shankar Matam, and I'm qualified in the SDGs and governance from Netherlands, the Hague Academy, and I'm a research scholar in the developmental studies, not the child development, the SDG development studies, and I have a couple of other degrees in public health, hospital administration, psychology, and physiotherapy. I had an NGO which works in the rural area for the health accessibility, disability, and education, and then hospital. Mostly we focus on the corrective surgeries, Hope Neuro and Multi-Specialty Hospital, and then a college which provides BEd in special education, AHD, and PhD diploma in early intervention, and a couple of more courses to come up. So I would not prefer to talk about what is the definition of disability, awareness, or etc., since the time is quite less. So I would like to keep the boundaries set. The awareness of what, who should be aware, and to what extent they should be aware. What exactly community means, what are the boundaries of community, and how community can participate, and one case study. So basically, people who should be aware of things are: one is PWD themselves, to the extent that intellectuality allows them permits. Second, families of the PWD. Third, professionals working for the PWD, like you and me. And fourth, who are not working directly for the PWDs, are not affected by the disability in any of the way. This is another community, like policy makers, government officials, private practitioners, investors, vendors, divers, anybody else other than PWD, person with disability, family with a PWD, professionals working for the PWD, anybody else, they also need certain awareness. The scope of awareness, what these four groups should know, is different. So what I exactly feel is that there are four aspects of knowing things, being aware. One is rights, second is responsibility, third is sense, fourth is knowledge. Rights, PWD should know the rights, families should know the rights, and professionals working for the PWD should know the rights. We have got even CRPD, United Nations Convention of the Rights of Persons with Disabilities, which is an international agency working under the UNO guidelines. And its follower in India is RPWD Act, which has come, and every state has got their own RPWD Act, and RPWD Act has got multiple sections and multiple subsections, clauses, etc., etc. And all the acts in India or elsewhere in India, they give the guidelines in general. They don't give a specific rules how an act has to be implemented. But the state government, central government has to make the programs and schemes where this act become into a concrete action to provide the responsibilities. So the knowledge of rights in act becoming into action is what requires an effort from the policymakers and bureaucrats and government officials, civil society, who has to bring it into action. And the rights of the professionals is to seek such kind of action being taken by the administration and by the policy makers, apart from the PWDs themselves and the families of PWDs. Responsibilities. As a rehabilitation professionals, we all have responsibilities working at the individual capacity or based upon the guidelines of the university or institute or the organization we are working. But apart from the professionals, there are the rights of the people who are not either affected by the PWD or working in the rehabilitation institutions. Like if I say that a person working in the HMDA has a responsibility towards PWD, the question comes little like quite how come a person working in water supplies is responsible for the PWD? Let us try to answer as the discussion goes further. If a person working in the agriculture department of the district or a state is also responsible for the welfare of the PWD, there is some way that we can relate it. That's where the community comes, community education or community participation comes into the roles. So these are the general things that we need to be aware of how to deal with persons with disabilities. Like there are theories like it has started with sympathy and then empathy and then the inclusion and then a couple of other things. What are the social etiquette that a person has to maintain when they are dealing with the PWD? So these are the things related to the sense and sensibilities. This is something which we need to be aware, and we all must be aware, and even people also are getting aware of how to maintain the etiquette with the PWD through different social media and other channels. The last thing is about this knowledge. This is the most important things. If anybody wanted to work for PWD also, there should be sufficient knowledge should be there to use such kind of tools or techniques like before this we were talking about artificial intelligence. It's a knowledge that parents or the rehabilitation professionals or the community should know to practice when they're going to. So what I exactly mean to say is that there are 4 aspects of the awareness: rights, responsibilities, sense and sensibilities, and the knowledge. These are the 4 aspects that we need to work. Let us skip this slide. And these are general awareness where we should not say that PWDs clustering special privileges should not be given because they are equal among all of us. So there are no special privileges. They should not be segregated or made separate or kept away like clustering, or we should not feel sympathetic towards them. Sorry, these are all general awareness. You all might be knowing it. So awareness of responsibilities. I think everybody should be aware of the responsibilities towards the PWD, policymakers, private systems, government systems, everybody. What are the responsibilities? I'll explain in the next slide. So when it comes to someone wanted to work about making responsibilities as a part of their work, be it individual, professional, or practice, whatever it is. 2 things that we need to remember. One is inclusion. Second is equity and equality. Like we have got RPWD Act saying that equal opportunities, equal participation, equal rights, etc. So this picture will help you to understand what is the difference between the inequality, equity, equality, and justice. So if you see the inequality, you can see this tree, the tree which is having apples or mangoes left to your imagination is system. And the person who is sitting with a question mark on the head is a PWD, a society of the PWD. The other side person who is receiving apple is a normal society, a healthy society. So it is unequal. Now if you go to the equality, you can see that there is a kind of stair is given, a stepper is given where both steppers are equal opportunities are provided. But is the person with disability able to access to the apples? No. So equality is explained here, but did the person with disability has received his benefit? No. So if you see the third part, equity. In the equity, the stepper is little taller than the other person, the mainstream person. Again here the person with disability is not getting his apples. So it is said as equity, but he is not receiving the benefits. So the 4 pictures, justice, where the system is corrected straight. Apples are distributed equally, and both of them are getting equal opportunities, equal participation, equal rights. I think we are somewhere stuck at equality, equal opportunities, and we need to move towards justice. So this picture will explain exactly how we all should feel responsible in making a PWD to receive their benefits of their due. So next thing is equity. Equal to this, you might have seen actually what was exclusion, what was separation, what was integration, which was practiced a decade ago, and now it is inclusion, which we are practicing now. So with these two pictures in the baseline, I would like to take you forward that how a development of the PWD should happen through the lens of sustainable developmental goals, which you all might have heard or you might have seen this picture. Sustainable developmental goals are 17 developmental goals, which are like no poverty, zero hunger, couple of things. So we need to emphasize or see the development of PWD through the lens of sustainable developmental goals. Let us say the first one, the poverty. Poverty has got a direct relationship with disability. It is like the more poverty, the more disabled people. Disability leads to more poverty. So if at all any system is working or if any person is working for the development of the PWD at the community level, the first focus should be there on how a person with disability can be brought out of the poverty by engaging the available scheme. Like suppose if you take Telangana state, I think my friend Srivasa will be telling about how poverty is being tried to elevate by giving monthly 3,000 rupees pension scheme to the person with disabilities, or making them part of Narega scheme, or giving some other benefits, how they have been brought forward out of the poverty. So any kind of scheme, be it a private practitioner or be it a government practitioner, be it a private vendor, we have to ensure that my charges or my practice or my system or my institution, is it going to help the PWD to get more poorer or becoming better? This is something we need to feel responsible while working for the PWDs in the community. Number two is about hunger. Food security is most important aspect. And I was mentioning that how an agriculture officer feels himself as responsible or should feel himself responsible as how a person with disability can be included in the food security practices. Most of the people in India, 72% of the people in the present day are dependent on the agri and the allied agri-based activities for the livelihood. And persons with disabilities are mostly in the rural area and they don't have a livelihood measure. But how to make a person with disability to become inclusive farming? See, a term you need to remember. Inclusion does not end up only with inclusive education. Inclusive farming also is one of the subjects that you all can feel, you can practice somewhere in the future lifetime if you are interested. We can have inclusive farming tools which can be accommodated for the person with disability, like farming, like an inclusive sickle, inclusive weeder, inclusive cutter, inclusive sower. We have worked with that, with IFAD, Indian International Fund for Agricultural Development. They have a project where farming can be made inclusive. So there are vegetable, livestock, dairy, poultry, backyard farming that can happen. So likewise, in the inclusive health, how many minutes? Yeah. So we have got, I think I should rush to case study straight away. So we have got inclusive health, disability inclusive school. I think the scope of subject is quite larger than 10 minutes. I wish I would have been given a little more larger time. I'll rush through. I'll put one more slide, last slide, inclusive law and justice. Do you know most of the people who go to the police station, we are too afraid to go to police station. And we don't know how to complain our lodge or complaint if something goes against. They ask us to write with our own pen and we will be afraid to tell. But how does a person with disability can go to police station? How a person with intellectual disability who is not cognizant or conscious about what kind of crime happened against her or him will go and tell to police station? Right. So I guess we should have more of inclusive law and justice, where we have got more of like a police system, disability inclusive law and justice. Police system, judges should be made more aware and responsible about how they can understand the problem of these things. So further about networking, lot of institutions has to be networked toward the increased awareness. Anyway, I have 2 more minutes to go, so I will talk about one of my case study which I have gone through in community participation activity. So in our community participation activity, we started a program called MARA, Mother as Rehabilitation Activist. You know what happened? We understood that we don't have primary resource persons working in the rural area. Like one of our friends was telling that there is Asha, an Anganwadi teacher in the village who works for the 3 to 6 year children. For the Asha worker who works for the below the age of 3 years for children and the pregnant women, and also neonatals to provide vaccination, etc. But we don't have anybody in the rural area working for the children with disabilities and all. So we started a program called MARA, Mother as Rehabilitation Activist, where a mother will provide therapy services to her own children. And we have trained around 4,000 mothers across Telangana districts like Mahabubnagar, Sangareddy, Vanaparthi and Peddapalli. After completing for 1 year training program for 15 days each with like reinforcement programs, 79% was only the success or we achieved the desired achievements happened from the mothers, because mother could not do the therapy at the home because mother has second child and mother has other activities to do. So that was a kind of partially successful. Then we started a second program called SDRC, where we called mother and child both in our center, stay for 15 days in a month, and then go back to home and work at home for 45 days, and again come back after 3 months. So in this program, the major problem was that lot of money that we were spending on the accommodation and food, which was 3 times higher than the cost that has been put up for the intervention. So we stopped with that program and we have gone for the third program called PRC, Primary Rehabilitation Center, where small centers were established at the mandal level, at taluka level, with area hospitals, where mother and child was brought to the center by themselves and they were taking treatment. Number was very good, but they were not coming regular because there was no public transportation. Autos were not accommodating these PWDs. Autos has to wait hours together to fill their number 8 capacity, and the child was crying. So they were not coming. So we have added something called, we have one more. So we have added one more electric auto for the PRC. So a lot of children were coming. So after the PRC has been added with the electric auto, lot of attendance was there. But the challenge was with funding. We could not get the funding. We applied for one scheme called DDRS, Deen Dayal Rehabilitation Scheme. And there were a lot of inspections, re-inspections were going on. Inspections officers are coming who are not aware of early intervention center. They were thinking that everything of disability rehabilitation is only a special school. We had a small room with one mat and small toys and one skill training person under Sahayogi National Trust scheme. But inspection officers were asking, where are the benches, where are the IU programs, where are that, where are this? So we could not get the funding. At last, with the help of some senior IAS officers, we could be able to push the file to the Delhi. In Delhi, they rejected the file saying that we should have persons with 40% disability only to get the funding. But why should we wait for 40% disability to do some kind of service? So these are all system barriers we felt. And then we thought of stopping it in totally. We let us not work in this field because we are not able to sustain financially. Then suddenly somebody from Orissa called up and they have asked us to start a program in Orissa. So we started in Orissa, in the area hospitals. We have 20 PRCs now working totally funded by government and externally working. As a closer, I'll show one. Can someone help me with the open website? So what I mean to say is that in community rehabilitation, one has to work with a lot of zeal and strength. It is not easy to get the funding. You need to engage with the community, and the community will not be very conducive with your ideas and with your practices. So at last we started something in Orissa. We are having 20 centers, and now it is going to be throughout Orissa state. And in Hyderabad, we have started one center in Women and Child Welfare Campus, Primary Rehabilitation Center, NIPD. Dr. Shilpa Manogna was a very crucial role in setting that center. So we have one PRC, Primary Rehabilitation Center. We thought we will start it as PHC. In health, we have got PHC. In rehabilitation, we should have PRC. Now PRC has become institutionalized. PRC has become a government program with one center in Telangana, 20 centers in Orissa. So now we are working to scale it up. So I think community activities, you go to the field, you engage community, you see all the problems, you be ready to face the challenges, you fight with officers, you fight with other obstacles, and then you make a model and redo the model and again and develop the best model, convince the government to accept the project as a project and fund and then scale it up. So this is our project in Orissa called IPU. You can see in the last, this is Sahara, this is our NGO which is working. It has been working in association with Orissa government and National Health Mission. I can show some of the reports, like how live reports we do generate. So if I have to see that how many beneficiaries came today, I can see here today 11 senior citizens came, 11 adults came, 1 child came, and from which village they came also I can capture. This is real-time cloud-based data being captured, which is much more easier for the officers to show it. And we are using this technique to show to the people that what is exactly happening in those centers. So we are convincing Jammu Kashmir government, West Bengal government in Bankura district, and Tripura government to establish more centers. And efforts is still on for Telangana. As of now, we are having one center by government of Telangana in Women and Child Welfare Department. Hopefully, we will get more and more such centers. So with that, hope I have completed my 10 minutes. I'm sure the subject is much more wider, larger, bigger than what we discussed. But maybe some other time we can think, we can discuss much more. Thank you so much. Any questions?
Thank you, Mr.
Thank you, Mr. Shankar Matam. It was a lucid presentation, and we have to, follow the time limit. That's why we'll take up the question answer session after all the presentations. So you may have a seat. Thank you so much, sir.
We would like to welcome Sri Rajendra, Assistant Director, Department of Disability.
Sorry, in place of Rajendra, Mr. Adul Srivastava has come from Department of Disability Welfare, Government of Telangana. So he is a disability rehabilitation consultant in Department of Disability Welfare, Government of Telangana. So he will be talking about innovations in disability assessment and services for PWD in Telangana.
Good afternoon, ladies and gentlemen. I am Atul Srivastav. I am a disability rehabilitation consultant in the Office of the State Commissioner for Persons with Disabilities. It is really a great pleasure and honor for me to be a part of this program in the National Conference on Transformative Solutions and Innovations in Disability Rehabilitation 2023. And I'm really delighted to share the innovative initiatives taken by the Government of Telangana for persons with disabilities. The Government of Telangana is very well committed for empowerment of persons with disabilities and has taken a number of unique schemes, programs and activities needed for empowerment of persons with disabilities. We have a separate department exclusively catering the needs of the person with disabilities, called as Department for Empowerment of Persons with Disabilities. And the main function of this department is to provide education, social security, financial incentives, as well as welfare programs and maintaining of specialist schools and residential schools for special residential school for visually impaired and hearing impaired, as well as providing technical know-hows to the person with disabilities. The main major schemes and programs available in Telangana for the empowerment of persons with disabilities are pre-matric and post-matric scholarship, economic rehabilitation schemes, marriage incentive awards, free distribution of assistive aids and appliances. We have Kalyan Lakshmi Pathakam or Shadi Mubarak, in which 25% extra, that is 1,25,000, is given to girl child who is PWD, and Asra disability pension at the rate of rupees 3,016 per month, irrespective of disability degree as well as age of the person, and as well as even gender also. And we have Arogya Shri health insurance scheme. We have one very powerful program called Kanti Velugu program, which was previously run in schools called Chinnari Chupu. And in that we have found that there are 5 lakhs children in the schools, different schools, who are not able to see the blackboard just because of lack of some reflection error. And when we have provided them, I think many of them have continued. If this program was not taken up, I think many of them would have become dropouts. and maybe they might have gone to criminality because they don't know why they were being punished. So based on that, similarly, we have this Kanti Velugu program where the universal eyesight assessment program is going on. We are providing 5% reservation to the person with disabilities in allotment of double bedroom housing schemes, and especially giving priority at the ground floor in allotment. 5% reservation to the in all poverty alleviation, welfare and departmental schemes, giving priority to women, and 4% reservation in direct recruitment in government institutions. Plus, at the same time, we are also continuing uh, special recruitment drive since 2002 onwards every year to fill the backlog posts meant for the person with disabilities. During the COVID-19, to reach the unreached, we have started a helpline for person with disabilities exclusively, 155326, and this helpline provides help. Help stands for health, education, livelihood, and person with disabilities support programs. We have 24 field response officers working in the districts, and special vehicles have been arranged to reach the needy PWDs. At the same time, we have received around 1,20,000 calls since May 2020. Majority of the calls which we have received were asking for some kind of disability certificates or pensions or like facilitation, and we have been resolving it at the earliest. We have a disability program, disability assessment and certification called SADRAM. Now it is a software for assessment of disability access, rehabilitation and empowerment, and this is a dynamic, well-enabled, web-enabled software which is meant for automation as well as decision support system to issue disability certificate. And we have also constituted medical board according to the RPWD Act for 21 categories of disabilities. So far, we have given disability certificates to around 8,38,036 people, out of which locomotor disability people are higher. There are 5 lakhs, then 79,000 hearing impaired, 42,000 mental illness, 93,000 intellectual disabled, and visually impaired 1,01,000, and multiple disability 3,315. We know the importance of assistive technology or device because it helps to improve their performance. It also helps to improve their productivity, mobility, communication, as well as participation in the society. As we are working for the equity, as we are working for inclusivity, we feel that innovative technology which is coming into picture has to be transferred to the person with disability, especially those who are living in the rural areas. So this taking into consideration that there's assistive devices can reduce the ill impact of disability on persons and stop further ill impact of or secondary complications in the life of a person, and as well as it gives some kind of security, confidence and greater independence. We have launched a special program on impact of innovative assistive devices. Since last few decades, we have found that a revolutionary change has come place in since science, medical science, microsurgeries, innovative technology, etc. And most of the manually run assistive devices are now being attached with the motor, and it's very easy for the people to use it. So government of Telangana, since formation of Telangana, that is from 2014 onward till date, has given assistive devices to a tune of 32 crores to around 40,000 beneficiaries. We also, if, since 2020 onwards, every year we have a in Telangana Innovative Cell in our IT department, and with our collaboration, we are every year conducting Assistive Technology Summit. And this summit is providing a common platform to all the entrepreneurs, experts, etc., to foster innovation in assistive technology. We are conducting exhibition in that case, we are conducting competitions, and we are trying our level best to see that Telangana become a hub for assistive technology innovations. So we are supporting all the startups who are coming forward for their incubation period, because the moment they come in, they are not their innovation may not be suitable for the going into market. So we are providing them all kind of help required, like quality control and further upscaling by providing them support. Uh, as we have conducted competition, we have seen that many number of organizations, institutions, especially all streams of engineering have come forward, because we believe that every person, if we are talking about inclusivity, every person who is potential professional must know what is person with disability. So we have encouraged him to give a project of assistive technology as well as accessibility. For example, any civil or engineer or architect, if at a school age, if he has any project on accessibility, whenever in future he will be planning, he will be adding this component automatically. And we have also rewarded those projects by giving them first, second, and third prizes, like even 2 lakhs rupees. And this year, a number of engineering institutions have come forward individually and group to participate in this competition. The assistive technology is transforming the complete life of the PWDs. And this TS, Telangana State Innovative Cell, is taking large scale awareness program for the students, especially from all streams. Like we are also taking people from MBA stream, because they are going to become HRs. They are going to recruit people, so they should know what is the requirements of the person with disability. We are also trying to take people from civil engineering, people architecture, electronics, and in other streams of engineering, so that they should have some kind of sensitization towards accessibility, innovation, and reciprocal assistive technology, so that it will be in their mind, it will be shown in their mind that in future they have to, whatever project they work on should have the component of accessibility as well as innovative technology in their projects. So they will be working in future to get the universal design, which is the main purpose of our RPWD Act. Thank you very much.
Thank you, Mr. Atul. We'll take up the question at the last. Thank you so much for a wonderful presentation.
We now request Shailaja Rao ma'am to give the presentation. The topic is Overview of Early Intervention Package by Madhuram Narayan Center. We welcome you, ma'am.
I'm thankful to Madhuram Narayan Center for allowing me to represent them, in a sense that they had their own prior commitments and it was a short notice when they were given invitation, but they wanted the concept to be shared. So I agreed to present on their behalf. However, if any questions are there, if I am not able to answer, I will definitely forward it to them and by email, and you will get the response. So Upanayan is the name of the package which they have developed for initially when they started this project in 1992. It was completed in 1994, and Mother Teresa was the one who blessed them and inaugurated the package. Professor Jayachandran Jayakrishna Swami and her husband, Air Vice Marshal, retired Air Vice Marshal Krishna Swami sir. Three of them were blessed by Mother Teresa, and that's how this initiative was, introduced into the public domain. Now, OpenN has traveled from 1994, and in the year 2009, not 90, 2020, UPNN is not the only program. They do many other programs, but Maduram Narayan Center as a unit merged with a state government department organization called Balamandir, which is a state orphanage home. So the reason why they merged it is they wanted to have an educational model from birth to 18 years. So this they thought would be a good idea, and there were a lot of children who had learning problems at Balamandir, where they used to take children after 6 years. 6 years to 18 years is the tenure there. Then the state government came up with that idea. If the experience of school readiness through Upanayan, which has been gained by the staff at Maduram Narayan Center, in short they call it MNC, if they could contribute their expertise and they could help children for smooth transition into regular education schools. So this merger was intended to give an inclusive education package. And therefore, Upanayan, again they decided 0 to 2 years was the first stage, then 2 to 6 years they have again added, and now they have converted it into software because they realized there is a lot of demand on distance mode support. So after the pandemic, the software idea came up, and that's how now it is called as Upanayan with Upanita software. That's the name, and it's an early intervention model. It covers children from birth to 9 years in terms of chronological age, but developmental age is 0 to 6 years. Introduction I've already told you, so I won't dwell on this. But this also I told you about the 1994 inauguration. But just shortly, what are conditions and who are the people who are associated with this? It's usually the developmental psychologists, special educators, experts from speech and audiology, neonatology, because some babies come very early to them, and they have a very good network with local hospitals, and experts from nutrition, physiotherapy, occupational therapy, etc. So this is a multidisciplinary package. Then when we look at the features, the package is divided into 3 parts: 0 to 2, 2 to 4, and 4 to 6. So whenever a child is transitioning, these are the age groups that they are divided, and that's how the promotional criteria is being applied. As I said, it's a multidisciplinary package. So it has a contribution right from screening, assessment, intervention building, as well as evaluation. The multidisciplinary team is consistently associated with the child, but it is coordinated on a long run for a sustainable coordination by the special teacher. Whoever is the special teacher associated in the team, she becomes the transdisciplinary representative from the team. So that is the model. And when they started working on the screening materials and assessment materials, they have come up with an excellent software content for it for all 0 to 6 years. So I happened to visit Maduram Narayan Center for some other reason, and then they shared this idea. To my surprise, I felt that this particular, of course, a medical expert group has to also review it, but from my experience in the field of disability, I felt that all the 21 categories, the red flags could be raised through using this screening and assessment material, right from 0 to 6 years, whatever age group we can target the children, or whenever they happen to contact the professional help. These materials for assessment are so sensitive, so much in detail, and so much evidence-based, and it is coordinated by the multidisciplinary team throughout. Every 3 months, the multidisciplinary team looks into the programming, gives their inputs, and then reviews and modifies the program. So that is the package design that they have developed. And therefore I thought, and then I asked them, has it been field tried? They said yes, it has been field tried in 32 districts of Tamil Nadu for the last 3 years. And in addition to that, they tried trying out for autism. When I said that this can be applicable for 21 categories, they said we have already tried for autism. And they shared their experience,
They have trained 15 NGOs who are working for target population of ASD group from 0 to 6 years, and they have a good network with the early intervention centers across Tamil Nadu, and that's how those 32 districts they have been able to implement it in. So this is the status of their not just the designing of the tool, but also taking it to the field. It has a 3 years of solid evidence-based data, which they are willing to, and they have already shared it with the state government, but they are willing to share with any other takers. So that's the reason I'm presenting it in this forum. And anybody wants to work in the field of an early intervention, and they are already associated with early intervention centers across the states, respective states. You can check with this, and maybe it'll be a good idea to have a network with them. My vision for this package was that it should become an integral part of RCI course curriculum because it is teacher friendly, it is parent friendly, and it can be easily translated into the local culture because it has been drawn from the cultural practices. Therefore, it's very suitable for Indian condition and it's an indigenous tool. So these are the materials, like I said, Sadhya, and then now the Madhuram Narayan Center package. If we can push RCI to look into Indian solutions and strengthen the courses for that respective age groups that we are trying to develop the functionaries. So my vision was that these kind of experiments must further be coordinated and connected with other existing models where the teachers are being trained, parents are being supported, caregivers programs, all these target groups we can combine. And if this kind of an inclusive training model, if we can come up with, I think at every point of time, whatever may be the lifespan needs of the child, we have solutions available from the Indian context. This I've already told you that the special educator is the main coordinator for the team, whereas the multidisciplinary team needs. Yeah, thank you. I've almost covered everything. So the data which is stored and documented has been made computer friendly and easy for the teachers to compute. So it will not be difficult. The only concern was how do we make it simplified for parents who use mobile. So it has to be adapted to mobile technology. So the design has been developed by a company whom Madhuram Narayan Center has engaged for developing this software. So they are still working on how to make it mobile based support. The cost of it, if anybody is interested in exploring this model, the cost of the package is around 15,200, but the software and the maintenance for 1 year, and there'll be 3 training visits by the software company team, so that the institution which is installed and when they want to implement it, 3 visits have been included in the cost of this 25,000 for the software. Installation is free, and you can use it for 1 year, and the team from MNC will continue to support if you enter into an MOU. This is the terms and conditions. How do I know this? Because Ambika Shishu Kendra, which I'm now I'm supporting them with honorary services, they have already entered. They're getting into the process is on. The negotiations are going on. So that is how I got all these details. So I thought it will be useful to share it in the forum. It is in public domain now, and anybody interested can contact them. And Mrs. Jaya Krishna Swami, she's the director right now, and their administrative coordinator is one Mr. Krishnan. So I have given the contact details in the last slide. So anybody wants, you can take the PPT and you can keep the contact details for further communication. So I think I thank MNC for giving me this opportunity, and I thank NIPIT organizers to allow me to present this on behalf of MNC. Any questions, I'll be glad to have answered.
Now, I would like to invite questions from each of the presenter, because all 3 have covered mostly all the things. Shalja madam have covered, early intervention, how we can identify, and Atul sir covered, schemes and benefits which is given by the state of Telangana, and Shankar sir has, given the importance about how community can be, one of the important role community can be played. So we would like to take any query, any question, suggestion from the audience.
Yeah, I have the one question from the Mr. Atul from the government of Telangana. I want to know the what is the process of certification of autism and ESLD and the status also how much has been done and where it is available.
Uh, the disability certificate is being provided by the SERP, that is Society for Elimination of Rural Poverty. It is coming under the Panchayat Raj and Rural Development Department, and in collaboration with the Medical Health Department. So, as far as the RPWD Act 2016 is concerned, we have received the guidelines from the Government of India, and the medical boards have been already constituted. The work for computer for making the software and making it automated to take a decision about the percentage has already been completed, and we are in touch with the different groups like medical department, our department, as well as we are trying to run pilot projects so that it can come soon in practice. I think we will be soon launching it. Thank you very much.
Sir, can I just
Any timeline?
No, 1 minute, Dr. Chaudhary. Can I just, sir? Sorry for my humble intervention, but it is for larger gain. Autism is not included in the GO, which has been issued by Telangana State. And I'm sure, even though there is a gazette document from central government, you're right about it. But until unless it is incorporated into Sadharam and in the GO, then the whatever you're visualizing will be the next stages will not happen. So please, on behalf of, in the larger interest, can you please sensitize the group concerned that autism has to be included because it has very clear guidelines. It is not at all difficult. And also, Dr. Sarojarya is the author of ESA tool, which is the basis of the guidelines for autism. If you approach NIPID, they surely will be able to support you on this. It will not be a difficult thing at all. Okay, sir.
I assure you, madam, that I have noted it down. I will be taking the, as you have said, because we also wanted nobody to be left out. We are working with that to put in our mind that nobody should be left out. If somebody is left out anytime by anybody's fault, I think generations will suffer. So just now I have spoken to you, ma'am, and you have given me that clue. I will certainly. I'll.
Sir, do I have your...
So I will certainly.
NIPID can help them, sir, to fill
Yes,
that gap.
I will be in touch with everyone, every stakeholder, and I will try to see that a meeting is concluded between the NIPID as well as all the experts. Thank you very much.
I have a question for Dr. Shelja. The software that you talked about, Upnita and others, you said that can you make it clear where the data of the participants who are evaluated by teachers and their data is entered into the software, where will it be stored? Will it be stored on the cloud, or will the school have total control over the data? Because there would be privacy concerns otherwise.
Yes.
If the data went on to the cloud and the MNC who had developed the software.
So madam, there are security systems to prevent indiscriminate access or even tampering with the tool. So both ways they have already taken care of the security systems in place. The company which they have engaged have already looked into that. Second, it has two versions of it. Hard copy, which can be stored in the school. Those who cannot have technology infrastructure, they can use the hard version. But those who have technology and want to have a more sophisticated storage and also retrievable data, they can use the software. So they have kept both options open. So in the 32 districts which they have tried out, I was told, few of the districts the infrastructure support was not there. So they have tried out the hard version. So both models are available. I think I've answered your question, madam. Anything else needs to be...
Shailaja madam, actually I have a question on the same lines. If you know, NIPID has also developed a software for 0 to 6 years for the Cross Disability Early Intervention Center. And we have, all aspects of all disabilities and all
assessment requirements, including the checklist, tests, inventory is also included in that. So I just want to know, but here you're talking about teachers also for a 0 to 6 group. So can you just elaborate, is it an assessment for rehabilitation followed by education, or how does it work actually?
It runs from screening, assessment, intervention, and evaluation, and it runs up to the time when the child has to be placed into primary school. So it has an inclusive and a comprehensive package. It is not just the medical examination and diagnosis or a review, a periodical screening of developmental status of the child or the profile, but it also takes care of the educational, the social context, the parenting support, all those aspects are taken up.
Have you seen our software?
I have not. I would
I
like
will
to
request
see.
you, ma'am. Actually, because now so that you have access to that software, I would request you to kindly look our software also, because Snippet would certainly be interested if there is anything add-on value from what we have actually developed. And you said it's all for 21 disabilities, right?
I said that's my, limited perception, but I would keep it open for others to examine. In fact, they also said that we are trying other disabilities, we are field trying it. They began with autism, but they're not claiming it. It is my recommendation. When I saw their materials, it is so beautifully and so neatly measurable and evidence-based documentation they have done, even with the tests as well as they have medical and non-medical tests also, like cognitive. They have taken into consideration the cultural practices. How does the culture, perceive the developmental level of the child? How do they equate the child is on par with the peer group? So those kind of things, because their Madhuram Narayan Center is a center which works through parents. They don't just train teachers; they actually work with the parents. So whatever they develop is done based on the direct experience of the parents. So parents are the stakeholders, very strong stakeholders. So most of their information for intervention has been drawn, even the food habits, nutritional support has been taken from the local, the local practices. So
then would it be applicable to North India?
Maybe some adaptations would be required because
That's
they've
what.
done it only
Because
in
we
Tamil
are
Nadu.
such a highly culturally diverse place.
They are also of that opinion.
Yeah.
That's why when I suggested, why aren't you keeping it open for the country to see if they can take, because it's an Indian-based, culture-based support. At least the 4 states in the south, you can keep. So they were very humble in saying, Madam, we have done it in Tamil in the 3 years time. Maybe we need to further work on it and then adapt it. So they are willing to come into collaboration with any state departments or organizations and escalate the cultural applicability.
Very nice.
They're
ma'am.
open to it.
Very nice. In fact, we would like to have a look at that. Meanwhile, I suggest, ma'am, since you have seen that, please have a look at our Cross Disability Early Intervention Center software, which actually is more or less on the same lines with very detailed assessment. In fact, all aspects, and the reason why we went into so many details is sometimes if any professional misses out on a particular area, because of the software, he's reminded, okay, I need to look into this parameter also. So that way, it's a very detailed assessment what we have developed, and we have implemented in not only in NIPED, in our CRCs and also now in RCs also. So I would request you to kindly look and give us a feedback so that we will actually also go into that. And that goes for all the participants also. If anybody is interested, maybe you can, since you're all here and the software is very much active, it's all paperless software where we do all these things, and this is up to the preschool, that is 6 years, where even the children are put through education and all. And Dr. Shravan Reddy is here. He is the in charge of that. Maybe after this conference also, you can just have a look at the software. Yeah. Thank you.
One more information, because when we went approached them saying we want training on that, it's a 3 months training. 5 days they train the team in Chennai right now, the way things are. But in future they plan to go to whichever place. But before the training, they will actually look at the cultural applicability, and then they will finalize the training, whatever adaptations. So why I'm saying this is, when we went and approached, they are going to come next month. It's a start in the month of June. So they'll be visiting us. They'll be studying the kind of case studies that we have, and then see what changes have to be done. Then they will start the training program, that 3 months training program. So they'll not charge extra for coming and examining the conditions there and what is the need of the target population there. So this is their way of working right now.
Okay, thank you.
My question is to Atul sir from Government of Telangana. Sir, for ID children from Government of Telangana, are you giving any aids and appliances, sir, like for locomotor,
hearing impairment you are giving. For ID children, you are giving any aids and appliances from particularly from government of Telangana, any provisions?
Any disability specific assistive device can be given. We are adding on, increasing through our innovative cell any useful assistive device if it is available. Certainly, we will try to consider it. But at present, we are giving only TLMs, special TLMs. I think NMH is providing us, and we are just passing on to the institutions. But if there is any other suitable TLM which can be useful to any of the intellectual disabled person, I think we will be very happy to incorporate in our list, because we are looking for that only. In our we are conducting group discussions with Telangana Innovative Cell, innovative startups, entrepreneurs, as well as CSR. So we are trying to see that the money which has been coming from the CSR should go to the right channel, and that should get very effective quality of assistive devices, so that people get benefited. If you have any list, you can pass it to me. I will certainly put it to our government.
One more question for Mr. Ratul. We are getting a lot of clients with a person with intellectual disability, and they are coming with a problem that window of Sadaram is closed for registration, and they are not getting certificate. Can you comment?
No, during due to COVID, there was a lot of difficulty. 2 years backlog. So that backlog is still impacting. The second thing is that at present we are concentrating on only 7 disabilities. Though in 7 disabilities we are covering around all 18 disabilities which are in RPWD Act. But not as this. For example, dwarf, we are not giving as dwarf, but we are giving it as a locomotor disability. So we are covering. So I think we'll certainly try to provide all kind of helps, whatever is required.
Hello, sir. Good evening. My question is to you, sir. I want to ask: is there is any rule? Is there is any rule ki if in a family 2 children are there with the disability, one child is getting a pension and Sadaram certificate, and other is not getting? So I want to know that. Please clarify it. I want to know it, sir. Because mostly parents comes and say to us.
Yeah, that is true. That problem is existing. Anybody in the family, if he is getting a pension, then other person will not get the pension. So this problem is there, and we have received a lot of complaints. So we have approached the government, saying that those people, especially intellectual disabled children who are there, because in pension, for example, family pension can be passed throughout, but as far as disability, ASRA disability pension is concerned, there are some eligible criteria. The amount is very high, that is 3016, which is nowhere in India, and the impact is also there. It has some guidelines, but we have asked or submitted a proposal to the government. It is under consideration, especially considering the intellectual disabled.
Thank you, sir. Thank you so much.
Excuse me, before you ask any question, ma'am, I just have to say that this will be the last question of the session. Yeah.
Thank you. I think we can take 2 questions because there are 2 persons waiting since long.
Fine, yeah, okay.
The final
so two questions, yeah, ma'am, final 2 questions. Last 2 questions, yeah.
Thank you, ma'am. Thanks for the opportunity. Sir, good evening, Atul. Sir, my question is for you. This is Rupavati. I'm a research scholar from Ramakrishna Mission, Coimbatore. I just want to know if the government of Telangana is maintaining any separate mortality data, the reason for death, the age of death and the kind of disability, because unless we know the reason and span and the reason for death for persons of disability, whatever we uh, give to them by way of employment quota or subsidies or schemes, I think they find a bit difficult in matching that. I just want to know if are we maintaining any separate data, mortality data?
There are data available with the medical and health department because whenever the certificates are issued and a number of people are applying for the pensions, and whenever some eventuality or something wrong happens, then that place will be occupied by another person, so automatically this data is available.
Is it available for researchers? How do we get access?
For researchers, you have to approach the SERP department and you have to make a request, and with data consultancy you will be getting it. But it is their discretion and not ours.
All right, thank you.
Thank you for considering my question. And this question is to Shailaja ma'am. Shailaja ma'am, you were speaking about the Upanayan scale, and you also mentioned about the distance mode support. So when it is being done, in your point of view, what would be the rate of validity or reliability? And in case, do we get the actual, the information about the concerns of the student? I mean, I'm not limiting to the 21 disabilities or anything. I cannot specify here. But when you just mentioned about the distance mode, what would be your thought and what is your idea on that? Thank you so much for considering.
I appreciate the question, but I'm not competent to answer that because I am also the beneficiary of it. However, knowing the track record of Madaram Narayan Center, who has been very, very systematic and very methodical in terms of research and development mode. So it's an R&D mode that they have already done. Luckily, what happened was the software was not developed before the pandemic period. They were doing the hard version. The hard version has the validity part, but what happened during the pandemic was almost about 1.5 years, the children were left out. They could not travel. So they were compelled to look into the other option. So I'm sure they will have an answer, but I will not be able to tell you right now. I will find out and get back to you. If you leave your email, I will connect you to them.
So first I would like to congratulate all of the presenter. Ma'am, as you said that early intervention, your program, software program will help us to identify or to do the management. And sir, you have presented so well about, and we are aware about Sadaram, and we will go through the website. And sir, you have shared your valuable the community related orientation program and other things. So thank you very much. And because all this area is very, very important for the disability management. So thank you very much.
Thank you, presenters, for having wonderful presentation. So I request the chairperson of the session, Dr. Amada Sahai, to felicitate the presenters with a memento.
have a group photo.
Sir, I request you all to please come. Dr. Shravan, by default you were supposed to be here, so you can come now. You were supposed to be here. Ma'am.
Thank you all, and now we'll have a short tea break. So you all are requested to gather here as early as possible.